Morning.
Good morning, everybody. Can you hear me? It's on. I want to welcome you to our MDS Patient and Caregiver Forum today. I'm Audrey Hassan, the patient liaison with the MDS Foundation, and I want to thank you all for choosing to spend your Saturday with us here today. It's an honor and a pleasure to have as our guest speakers today Dr. Peter Greenberg, who is also a member of our board of directors, Dr. Alex Chelation, Dr. Lori Muffley, and Mary Thomas, who is a member of our board of our nurse leadership board at the MDS Foundation. Just a few housekeeping rules. We are taping the forum. It'll be available up on our website after the meeting. The bathrooms are down the hall and around the corner, and there are also bathrooms downstairs and across the hall if you need. Please make yourselves at home. If you need to use the restrooms, it's very informal. You can get up during the talk. There are also refreshments in the back. We want you to be comfortable. So please, without further ado, I'd like to get the program started for you. Please help me in welcoming Dr. Peter Greenberg.
Good morning, everyone.
Morning.
Can you hear me all right? So maybe I need to use this. Let's see what happens. We okay now?
No.
Looks like it's on. It's on.
Can you hear me now? Great. We want to welcome you today and hope this will be useful for you. We have 4 speakers that will try to put MDS into perspective. We want there also to be, we also want there to be time. We also want there to be time for questions. So at the end of each speech, there will be time for you to answer questions, ask questions as much as possible. Can you hear me still at the back? How is it?
It needs to be louder, sir.
Yeah.
Put it close to your mouth.
Can you hear me now?
Yes.
Yeah.
There is a speaker back here, I think.
Okay, so as you see, I'll be talking about the disease and its treatments. Following me will be Dr. Alex Chelation, who'll talk about molecular understanding of this disease. Lori Muffley will talk about bone marrow transplants for MDS patients. And after lunch, Mary Thomas will be discussing quality of life with you. And again, questions afterward will be most appreciated. So some of the questions that you will likely have will include these. What is MDS? What does it mean for my life? Is there treatment for it? How should I be treated? When and why? And a lot of this relates to the uncertainty that occurs in your minds and also in the minds of physicians about what's next. So I hope to put this into some perspective. What's the nature of this disease? It's chronic. It's heterogeneous. It's not one illness, it's multiple groups of diseases. There's symptomatic blood counts that may be low, called cytopenias. Patients are generally elderly. What does that mean? Usually 10 years older than the speaker. I mean that's one possibility. But I'll let you use your own imagination for that. Comorbid conditions, that is, other illnesses can occur in people over the age of, say, 60 or 70. Potential progression to acute leukemia is the real devil, and the question is why and when that will happen. And what do we know about potential therapies and the impact on quality of life? So these will be covered. Now, as you can see here, the disease, as well as many other hematologic malignancies and cancers in general, begin to take off at the age of 60. and 70. And so the incidence of the disease really increases markedly as we age. And so what are the features that will give us some information about what's our prognosis? What are things going to happen to us over the next few years? The things that we look at are clinical and molecular. Blood counts, bone marrow blasts, and what are the cytogenetics? Those are the key features that we look at that help us decide this. Other features include age and a number of other features that we look at. And then if you have treatment, how is your response? If it's good, generally that's a positive indication. If not, then the question is what's next? Molecular, Dr. Chelation will be talking about a number of these molecular issues in much more detail, but I'll be talking about some specific mutations and the number of mutations that may occur. We have a catalog of alphabetically named diseases that are subgroups of patients with MDS based on their bone marrow blasts. So when your doctor gets a bone marrow, he will look to see what proportion of blasts that are there. The main point is it greater or less than 10%, and then what should we do about it? And there are different names that are given to these diseases depending on what is found morphologically. Now, as a result of the issue of how we deal with prognosis, an international group has been set up, and from 11 countries, 7,000 patients, and a system then developed in which one looked at bone marrow blasts greater or less than 10%. What are the cytogenetics, your bone marrow chromosome? What groups were they? How abnormal were they? And then how low were your blood counts? And those are the key features that go into prognostic indications, as well as age. And so what one found was that there are 5 subgroups of patients with MDS. Depending on this, if you put all those 3 features together, there are patients that have, in the upper 2 columns there, very low and low risk patients. Those are lower risk. In the bottom, higher risk patients. And then there's intermediate. And we manage patients depending on which subgroup you happen to be in. For patients with lower risk disease, the main point is to try to improve your blood counts. For patients with higher risk disease, and that is higher risk for potential development of acute leukemia, we try to give you treatment that will modify the natural history of the disease. So those are the things that we as physicians try to take into account when evaluating your specific stage. But in addition, there are recurrent mutations, changes within the cells of your bone marrow, and these can be present in a higher proportion or a lower proportion of patients. But as you can see, there are many, perhaps 20 possibilities that can occur, of which the ones that are in bold are relatively poor prognosis. That is, there are 5 that we look at to see if they will be additive to the features that I told you a moment ago, the clinical features of the IPSS, what your subgroup is. And so we look now almost routinely to see what your cytogenetic, what your molecular features show, what the mutations are. In addition, there is one that has a good prognostic feature, and that is this one right here, SF3B1. So those are patients that often associated with patients that have what's called ring sideroblasts, a group of cells within your bone marrow that have a good prognosis. In addition, the number of abnormalities and mutations also make a difference as to how you will do. So again, these are things that we look at when we evaluate your blood cells and your bone marrow for prognosis. Now, there have been a number of approvals for drugs for MDS over the last 10, 20 years. And as you know, and many of you have been treated with some of these, erythropoietin and darbepoetin, early evaluation, G-Csf for patients with infections. And then in 2004 and 2006, these 2 drugs, azacitidine and decitabine, were approved. And since then, there's been no major addition. So we're talking about almost 10 years since there's been any attempt to have a drug that's been evaluable that changed the natural history of this disease. So we have been looking and are still looking to see what are the best next drugs for your illness. These two drugs are called hypomethylating agents and may have potential utility for a group of patients, particularly high-risk patients. Lenalidomide is a drug that's very useful for a group of patients with a chromosomal abnormality called 5q-. So that's one subset in which a high proportion of patients may respond, and we'll talk about that more in a moment. Deferasirox is a drug that is useful for iron overload patients, patients that have a lot of iron overload because of transfusions. We then can provide this drug if needed, and we'll be talking about that. These two drugs here, romoplastin and eltrombopag, these are drugs that can improve platelet counts. They're not approved for this indication as yet, but they are available, and sometimes we do use them for changing platelet counts. So the National Comprehensive Cancer Network is an organization in which there are consensus groups of physicians that make decisions about management for patients with all cancers in this country. And so for MDS, the plans that have been suggested are to evaluate patients if they have clinically relevant low blood counts. Not just are they low, but do they make a difference for you? In other words, are you having an anemia that's causing fatigue, having a low white count with lots of infections? Is your platelet count making you susceptible to bleeding? So it's not just low blood counts, but how low they are. It's important. What's your performance status? Excellent, good, or poor? That makes a difference in whether or not you can, for example, receive high-intensity therapy. And then the prognostic risk category. And I've told you that there's lower risk and higher risk patients. And for the lower risk, hematologic improvement is the plan. For higher risk, the plan is for trying to alter disease natural history. And then, are you a stem cell transplant candidate? We look at the risk category, age, performance status, and whether you have a donor. And Dr. Muffley will be talking about that in great detail for not the next talk, but the second talk from now. Okay, so what kind of treatment is there? In blue, you have patients that are relatively lower risk, and in red, higher risk. And we have patients with 5q-, del5q. Lenalidomide, I just mentioned to you, is a drug that is quite useful. About 60% of patients will have improvement of their blood counts when they get this drug. For patients with refractory anemia and ring sideroblasts, we have erythropoietin and G-Csf. For all anemias, particularly those with low EPO levels, those individuals can get EPO alone. For some patients that are relatively young and have essentially low-risk disease, the use of immunotherapy can be useful. In those individuals that lack response to these, then clinical trials are suggested. Higher risk patients, I've mentioned azacitidine and decitabine. Those drugs, hypomethylating agents, are the standard agents that can be used. And I'll show you some evidence to suggest why that's being used in a moment. And for individuals that are young enough and who are in good enough shape and have a donor, transplant. And so you can see that most patients are not going to be receiving transplant as of yet. However, the hope is that this will be expanded over the next few years as donor selection and the ability to deal with the complications of transplant improve. Now, what about the use of erythropoietin? Most of you have been treated with one or another form of erythropoietin if you have anemia. Important to try to decide whether you should get that depends on what your baseline level of erythropoietin is. We all make that hormone in the kidney, but if it's relatively low, if the ferritin level is okay, and our risk score is relatively low, we can have up to an 80% chance of response. However, in higher risk individuals, or if the EPO level is very high, the response rate is much lower. So you can see that depending on these features, that goes into the equation as to whether or not you're recommended to have treatment with an erythropoietic substance. Lenalidomide. So this is a drug that is useful for patients with 5q-, and as you can see, in individuals with that subgroup, as I mentioned, 60%, durability of response can be quite good and is something that can be quite useful. I've mentioned azacitidine, and azacitidine is used for higher risk patients, and in that group of patients you can see survival is much improved compared to individuals that had conventional care. As a result, this drug was approved for use and is something that has been used since 2005 or 6. Decitabine has similar response rate and also is something that can be used, is usually used in situations when one needs to move more quickly. It works a little bit more rapidly than azacitidine. Now, there are molecular subgroups that I've just indicated, and Dr. Chelation will be talking about this in more detail. But I've mentioned SF3B1, it's good risk, and there's a new drug that's coming out. It's called luspatercept. It's in the midst of clinical trials, but those trials, the data for which will be valuable probably within the next year. If positive, the drug will be put on the market, will be FDA approved. About 60% of patients with ring sideroblasts are going to have responded and are likely to respond in future. So this will be a very valuable drug, most likely, that will be available within about a year for that subgroup of patients. Much less so for patients that have other forms of anemia. There are genes that are mutated in which there are splice gene modulators that are available. And this is something we'll talk about a little bit more detail. P53 is a mutation that is poor risk, and individuals that have this may respond to decitabine and also a new P53 modulator. IDH2, a mutation here. There's a new drug that has become available commercially and is available for this subgroup of patients. And Dr. Chelation will talk about that in more detail. And I've told you that for patients with 5q minus subtype of MDS, lenalidomide is a very useful drug. Now, what about iron chelation? As you know, individuals with getting many transfusions can have iron overload, and that can cause some degree of organ dysfunction, liver, heart, pancreas, pituitary. There are a variety of changes that can occur, but it takes a large number of transfusions for them to get that way. And so if patients have symptomatic anemia and further need for transfusions, and this number of transfusions that are low risk or bone marrow transplant candidates, the use of iron chelation is strongly considered and reasonable. However, there's no prospective data that say that this will change natural history outcome or organ function. We use it for patients that have pre-existing evidence of organ dysfunction, such as cardiac, hepatic, and endocrine, but that's the subgroup that is mainly important. If patient's serum ferritin is over 2,500, we attempt to decrease it down to 1,000. So the drugs that are available, desferrasirox or deferoxamine. As you notice, I'm not using the trade names. The trade names are not up here, and hopefully you're aware of what the trade names are. If not, raise your hand and I'll go through that with you in more detail. This is Exjade, deferrasirox, lenalidomide is Revlimid, azacitidine is Vidasa, decitabine is Dacogen. So those are the trade names, but I'm not putting them in writing here. What about future? The future, Dr. Chelation will go into the fact that there are diagnostic, prognostic, pathogenetic, and therapeutic reasons that one is going to look at the molecular mutations and the potential for them to be valuable in addition to the clinical features that I've already discussed with you. I've told you about luspatercept, and luspatercept is something that will likely be useful over the next few years for patients with ring sideroblast. And you're reading in the newspapers about immune therapy for a variety of cancers. Well, in MDS, that's also happening. And the main point is that if you have patients that have cancer cells that will block your own immune system from working, there's now antibodies that will go after these to stop the blockade and permit your T cells to work more effectively. And so there are clinical trials with that, including one that we're using here at Stanford to try to help responses. Splice gene mutations can occur in a substantial number of patients with MDS, acute leukemia, and chronic myelomonocytic leukemia. And so if one can block some of these mutations, it's possible useful responses could occur. And so here at Stanford in our MDS Center, we have a number of clinical trials that are ongoing. We've completed a trial with Xjade, with luspatercept. We've completed a trial with both of those. And we have ongoing a splice gene modulator trial that is something that are using for patients with lower and higher risk disease. And as I've mentioned, the immune therapy, azacitidine, plus that inhibitor is being used here at Stanford. And the people that are crucial for us here with the clinical trials, Savita Campbell, Mark Santos, and Alex Chelation, who you'll be hearing about, are doing a lot of the legwork for these trials. Resources for you, if you need information, include the MDS Foundation, where you've probably seen much of the information that comes. The Aplastic Anemia and MDS Foundation has some useful information as well. Leukemia and Lymphoma Society is here and also has a table that has lots of useful information you can get. The NCCN, you have access to that for looking at the guidelines and practice arrangements that are being used for these individuals, and the Stanford MDS Center. So the directions where the field is going is that we try to restructure classification and treatment. Molecular mutation of characteristics, biologically activated treatments that are going on, stem cell transformation and stem cell transplantation will occur, and quality of life evaluations. And all of these will be covered in the subsequent talks in this session. Biology and economic situations are also being considered, because certainly we need broad-based forums to try to decrease costs in patients for the drugs that are there. So with that, I want to thank you for your attention and open this up for some questions. Please. Yes.
Yes, I'd like to ask a question about iron overload.
Mike?
Sir. I have been getting blood. I've been about iron overload.
Yep.
I take Xjade, have an average ferritin of probably around 3,200. And just recently I was diagnosed with congestive heart failure. And I'm wondering, you mentioned the heart and the liver. Have you found in your particular practice that you do see patients from time to time where they do end up with congestive heart failure because of the iron overload?
The issue of congestive heart failure is a very important one. It's a major complication of patients with MDS, but be aware that it's also a very common abnormality in patients over the age of 60 and 65. So it's a disease that does occur independent of MDS, number one. Number two, anemia per se, long-standing anemia, can cause your heart to work too hard as well, and so can contribute to congestive heart failure. So management of congestive heart failure is very important, controlling the anemia and controlling the other potential causes for it. Now, in addition, it is true that patients with iron overload may develop some degree of iron deposition in the heart, and that can contribute. What hasn't been shown is that if one uses Xjade, you can modify this very effectively. Logic says for us to try to do that and make a change. But as you know, Mother Nature doesn't always speak the way we do as well, and the language we speak is not hers. So we use it for patients with congestive heart failure to try to decrease the problems, but realize that there are other approaches that are also needed for such patients.
Well, I'm having a cardiac MRI done on Tuesday, and that's what they're looking. They're doing a study to see about the iron on my heart. So.
That's right. So that is one of the things that one can tell whether or not there is increased iron overload that's occurring with you. And certainly if that's present, logic would say it's very reasonable to use it. Use Xjade to try to diminish the iron overload.
Thank you.
Okay. Yes.
Hello, Dr. Greenberg. So For a year, maybe 2 years, I was diagnosed with MDS, but the most recent bone marrow biopsy came back and said there wasn't a sign of MDS. Is that something that happens very often, and why?
Is that, have you been treated with anything?
Pardon?
Have you been treated with anything?
Revlimid just before that biopsy.
And when you were treated with, was there a reason you were treated with Revlimid? In other words, did you have anemia, and were you told that
Yes.
you had a chromosomal abnormality that was present?
Yes.
And was that 5q minus?
Pardon? No, it wasn't.
And so you had some abnormalities and anemia, and you were treated with Revlimid.
Yes.
Okay, well that's useful. I mean, when we use treatments of one kind or another, certainly we can diminish the number of blasts that are there and change the degree of dysplasia. However, whether or not you have MDS or not really requires review, not just of your marrow morphology, but as you'll hear from Dr. Chelation, mutations to know. Be that as it may, the fact that your marrow and your blood counts are normal is terrific. So occasionally one can get...
They're not normal.
They're not normal.
Some's not diagnosed with aplastic anemia. Or red cell aplasia, excuse me.
So you are still anemic, is
Yes.
that right? Well, certainly your MDS is not gone, and when we really need to evaluate what the cause of your persistent anemia is. Are you still taking Revlimid?
No.
All right. So that, again, as I'd mentioned, it's very good for patients with 5q minus. For those individuals that don't have that, it is not so effective, and other treatments really are necessary. Have you been treated with EPO, with Procrit, things of that nature?
No, because I had high numbers in those
Right.
cases.
So in individuals with very high levels of EPO and who don't respond, other therapies are needed, including potentially azacitidine. So I wouldn't use the term that you no longer have MDS, but you have an anemia that started with MDS that needs further evaluation.
Thank you.
Yeah. Yes.
Based on your experience, doctor, how often do you have the patients taking XJ that has a side effect of bleeding? Because for my mom's case, he has a very low platelets, like around 60. So she's really afraid of taking the XJ, but the ferritin of 1,200 right now. So we're like in dilemma if the side effect of XJ is really like
Right.
obvious.
Well, you mentioned that her ferritin is about 1,000, but what about the number of transfusions that she's had? Do you know?
Right now it's getting better. It used to be every 2 weeks, 2 packs of RBCs.
For how long has that been going on?
It's been like a year already.
Okay, so that means for a year, if she's had 4 units a month, do you think? Is that roughly what's happened?
Probably.
Okay, so she's had perhaps up to 40. So if she's had that number of transfusions, the potential for giving her XJ is reasonable. The main side effect of XJ is kidney problems, not so much bleeding. So kidney problems can become a problem, need to be monitored very carefully. Usually it doesn't cause problems with bleeding. So it may be her platelets per se are the things that are causing this rather than the XJ, or she may have some bleeding lesion somewhere that's causing a problem. So that needs to be looked at.
Okay, thank you, doctor.
Yeah. Yes, in the back? Yeah.
Yes, I've got MDS which brings sideroblasts, and I also have hematomacrosis. I'm looking to do a stem cell transplant. I see that having dental work is recommended before that, but I'm already starting, I've already finished my first round of chemo with azacitidine. Now, my platelets are still good, and I just have one cytopenia, which is the red blood cells at this point. Now, should I get my dental work done now before the rest of my counts presumably fall with the 2 more rounds of chemotherapy I've been scheduled to do? Presumably before a stem cell transplant after the beginning of the year here, or should I just just leave it as is?
Well, certainly prior to transplant, having dental work done effectively is a good idea, so any time between now and then would be very reasonable.
As long as my counts, my platelets are good?
Yes.
Okay, great, thank you.
Yes.
When do you start monitoring the iron level when the patient gets to many transfusion?
Right. When patients have received anywhere from 20 to 40 total units of transfusions, by definition, they're already iron overloaded. You don't need to even measure the ferritin, but you can measure it. So at that point in time, we begin that. And as I mentioned, whether or not to treat patients depends on whether they have pre-existing heart disease, whether they may be transplant candidates, whether they're low risk and are going to continue to receive many transfusions. So that's generally the plan for the use of XJ.
So there is no symptom, and you have...
No, you don't necessarily have any symptoms from iron overload. That's true. Mm-hmm.
Hi, Dr. Greenberg. I'm 2 years post BMT bone marrow transplant. And my question, I had these atrial contractions, ventricle contractions, palpitations. This was years before the BMT. But now it seems like I've been having frequent contractions, palpitations. And I think it's related to the iron overload. I'm getting phlebotomies, and my ferritin level has been dropping. It's, I think, about 1256 now, 1,000. But it seems like my palpitations have been increasing. Do you think it's related to this iron overload, my heart palpitations? That's my question.
One question would be, did you have many transfusions prior to your transplant?
Yes, I had maybe about 15 transfusions.
15?
Yeah. I was up to 3,200, the level, ferritin.
Yes, as I mentioned, the ferritin level is less important than the total number of transfusions. So it's not clear that you've had a huge number of red cells to give you adequate iron overload. As mentioned before, MRIs to look at your heart for iron is one way to evaluate that. However, more importantly, there is no problem with you getting iron chelation treatment, but more importantly, you need to have your cardiologist spend a lot of time with you on medication for management of your cardiac dysfunction.
Okay. Yeah, I'm getting phlebotomies now. I'm down to 1256.
Yeah.
So you advise just continue with the phlebotomies?
Phlebotomies are reasonable as long as your hemoglobin holds up okay. But I think most importantly is be sure that your cardiologist is in tune with what is going on.
Okay, I am seeing a cardiologist. She thinks it's minor. I went through all the cardiograms, the echocardiogram tests, and she advises just continue with the beta blockers.
Okay.
I don't know if that's, but do you think it's serious, palpitations? That's my last question.
Well, that's the question for your cardiologist, not for me at this moment.
Okay.
Right. Okay. Okay, one more question, maybe one or two questions. Yes, sir.
Hi. I had number 68 blood transfusion yesterday. My ferritin seems to jump all over the place. It was as high as 5,200.
Yes.
And then down to 3,200 and up to 4,800.
Right.
I've stopped right now taking XJ because I've been just started on Revlimid. This all came about 2 years ago. I've been dealing with carcinoid cancer for many years, and I went through the PRRT program, and all of a sudden had MDS. So I'm dealing with two different things here,
yeah.
And I just am curious about when their number of your ferritin is that high, Is there a certain limit that you see it go to when all of a sudden other things start to happen, or what? I'm getting around pretty good. I'm operating at a hemoglobin at 6 to 6.5 for the last couple of years, and getting around pretty good, but it's always in the back of my mind, where is this ferritin going?
Right. Well, the ferritin levels that you mentioned are quite variable. They can occur as increased in anybody with any inflammation or infection, but more importantly, they can change with transfusions themselves. So depending on how close you get the level drawn, after your transfusions, that level can jump. So as soon as you get a transfusion, it'll jump up, and then several weeks later it may decrease. So we don't necessarily use that as the marker. As I mentioned, it's the total number that's important. And if you've had that number, certainly you have some degree of iron overload. Whether it's playing a role in changing your outcome or your organ function is another question. And so that's something that one needs to evaluate your heart, liver, pancreas to see, and if it's there, then it's reasonable to do something with Exjade. Now, there's no contraindication to using that when you're getting Revlimid. Revlimid, the side effects are drop in blood count. So you drop in a platelet count and a white count. As long as that's monitored carefully, that's okay. There's nothing that says you shouldn't necessarily get Exjade during that time. It's your kidney function that's most important. Okay.
Thank you.
Perhaps one more question, yes.
At what point do you recommend that a person gets a blood transfusion?
Okay, that's a complicated question. You might think it's simple, in that a lot of it depends on the hospital itself. They have guidelines as to what level they will accept a transfusion. Some hospitals will say a hemoglobin of 9, some say 8, some say 7. What we use here is when people are symptomatic. So I don't use a number. And so in patients that have cardiopulmonary disease, they may be symptomatic at 9.5 or even 10. So that at that point in time, we'll say patients are symptomatic, give it to them there. And as mentioned, long-term anemias can cause cardiac dysfunction. So I think that one would try to keep people functional at a level that fits them. As people age, they may need a higher level. They're at higher altitude, they may need a higher level. So each individual, I think, needs to determine where is he symptomatic, notify his physician, and the physician then should have some degree of ability to respond to that.
What symptoms in particular are you?
Fatigue. Severe fatigue is really it. Dyspnea and fatigue, shortness of breath. Yes.
Thank you.
Related to that, what about for platelets? When do you decide that? Related to that question,
platelets. We don't transfuse for platelet. If platelets are below 10,000, that's usually a place where we consider transfusions. Less than 20,000, if there's bleeding, we will consider transfusions. So that's not hard or fast, but it's certainly important. Those issues are very important to try to determine as to when people will get transfusions. Yeah.
Here, right here.
Yes.
I was diagnosed with the 5Q, and I was on Revlimid for about 3 months.
Yes.
And then I had an allergic reaction to it, a swelling and a rash. Sure. And my counts were good then. They came back into the normal range. But anyway, they took me off of the Revlimid. Yeah. And for about 1.5 to 8 months, year and 8 months, my counts have been stable. Now, my question is, when my counts start dropping again, and to a certain point, say 10, can I start the Revlimid again, even though I did show a reaction to it?
Yes, that's a common, not a common problem, but it's something that happens not infrequently. And so in situations like that, occasionally what we'll use are steroids, prednisone, to try to diminish the allergic reaction that can occur with Revlimid. And that's something that you should be able to restart as long as it's covered well with the immunosuppressant that's there.
So it could bring them back up again for a second time?
That's right.
Okay.
Yeah. Okay, perhaps one last question.
Yeah, doctor, my wife was diagnosed with MDS 4 years ago, and she's not been receiving any medications, and she's been mildly anemic, and now the latest lab reports we got just 2 days ago suddenly showed a sudden drop in the hematocrit, the hemoglobin, and the red blood cell count, the lowest it's been in over 2 years. So I'm just wondering what action should we be taking?
What are the numbers? What's the number of the hemoglobin?
The hemoglobin is 10.8.
And what about the other blood counts are okay?
3.32 is the red blood cell.
And what about our white count and platelet count?
Oh, the platelet count, it's 204.
Okay. So a hemoglobin of 10, that begins to indicate that she may become symptomatic below 10. Many people are. It's not hazardous, but it's something that should be evaluated. Right at this point, then, what should happen is her blood should be drawn to see what her serum erythropoietin level is. If it's relatively low and she becomes symptomatic, she could start on Procrit, on some erythropoietic stimulating agent. So that's a standard approach. Your physician should just respond to your query about what to do for that hemoglobin of 10, and generally this is what would be done. It shows some change in the illness. It's possible the patient would need a repeat bone marrow soon as well to see what's going on. Okay, there'll be time for questions further after each of the talks and at the end of the day as well. So I'd like to now move on and introduce Dr. Alex Chelation, a fellow in hematology here, who's doing some great work in the clinic with clinical trials and evaluation of mutations in MDS. So Alex, please.
And I just want to remind everybody that if you have a question, just raise your hand. It's being audio recorded, so we want to make sure that your questions are being heard. Thank you.
Can everyone hear me? No? Oh, it's off. Alrighty. All right, let's give this another try. How's that coming through in the back? Good? Alrighty. Well, first of all, thank you, Dr. Greenberg, for that introduction, and thank you all for being here today on this Saturday morning. Today I wanted to spend a little time talking about some of the molecular advances in MDS and how they're starting to change how we not only look at the disease, but how we're starting to change management based on some of these mutations we're finding. So these are the topics I want us to cover today. So before we kind of delve into the actual nitty-gritty details, I want to review exactly what are genomics. And if we look back to our biology days in high school, we can see that each cell has a genome, and that genome is composed of chromosomes. And the chromosomes are basically collections of genes. And we have 46 chromosomes, 23 from mom and 23 from dad. Each chromosome is composed of a number of genes, and in total there's around 20,000 genes that we all have. And each gene actually is then further composed of nucleotides, and these are the A, C, T's, and G's, which actually make up our genetic code. Deviations, also known as mutations, and there's a few kind of mutations that can occur, alter this genetic code and sometimes cause the genes to function improperly, either turning on a gene when it should be off or turning off a gene when it should be on. And we think that that's really the fundamental basis of most malignancy, MDS being not excluded. So even though we've known this now for quite a while, a few decades, it's only recently that this has become clinically actionable. And just like there's been a rise in supercomputing power going from these large mainframes to mini computers and now personal computers that can do what these computers used to do in a fraction of the time and cost, there's been the same type of explosion in genetic sequencing technology. So while in the 60s and 70s, gel-based sequencing would take weeks to sometimes months or even longer to sequence just one gene, with the advent of Sanger sequencing in the 80s and 90s, that time was cut down to just a few weeks, and the costs started dropping into the tens of thousands of dollars. Still too expensive for routine clinical use. But now, just in the last decade, next generation sequencing, which we'll spend a little time talking more about later, has really cut down the cost to the point now that multiple genes can be sequenced for a cost in the few thousand of dollar range, usually in the now range of just a few days to sometimes weeks. And this has really allowed us to bring this knowledge into the clinic. And this is an extremely impressive graph. You can see this is Moore's law. This is the classical law that says how computing power increases with time. And below this, you can see that actually sequencing costs have dropped faster than Moore's law. And again, this has really opened up sequencing into the clinic. So while the first human genome took over 10 years and over $1 billion to sequence, currently an entire genome can be sequenced for a reagent cost of a few $1,000s in as short as just a few weeks. And so with this increase in technological sequencing capacity, we've had an extreme explosion in the number of genetic discoveries, both in cancer as well as non-cancerous state. And MDS has been no exception, and we've definitely benefited in the MDS community from all of these sequencing discoveries. So how does this relate to MDS, and what can sequencing and understanding of the genomics of MDS do for our patients? Well, historically, hematology and oncology has been really an imperfect art. So while in many disease states, response rates for various medicines have been fairly high, in oncology, across the board, the response rates to any individual therapy is fairly low. So for things like azacitidine or decitabine, the response rates are not 100%. We know that many patients who are treated with those therapies respond for a short amount of time, don't respond at all, or have a suboptimal response. And because of that, what we frequently do in MDS and many other malignancies is this kind of stepwise approach to treatment. We try one therapy. If it works, great. But if it doesn't, then we move on to therapy B, et cetera, and et cetera. And while this works, there is a problem. Using therapies that are ineffective is not only costly, but can take up time, and there are side effects that can be associated with the therapies. So if we could predict early which therapy is going to work for which patient, that would really be the end goal. And because of this, we're more and more starting to think about precision or personalized medicine. And this is really a subtype of medicine in oncology where we're trying to identify the right therapy and the right kind of prognosis for each individual patient. So historically, we've been looking at diagnoses in a histologic or morphologic manner. So these cells look this way, and we're going to group them as an MDS, with, for example, ring sideroblast. More and more, we're now adding molecular classifications to these pathological ones. So now we're saying that we have MDS with ring sideroblast and a mutation, and that mutation frequently for this subtype of disease is SF3B1, for example. So really the mutational status is helping to refine the diagnosis and starting to, early on now, to actually change management in some cases. So before we actually dive into the mutations, it's really good to kind of break down the mutations into two big subcategories. One of them are somatic mutations, and the other one are germline mutations. Somatic mutations are kind of these wear and tear mutations. They happen in all of our cells with age, and usually are accelerated by toxins like pollution and tobacco smoke. These mutations are not inherited, so there's no chance of passing these on to our children. While germline mutations are inherited mutations that are frequently passed down from generation to generation and can increase, in rare instances, risks for diseases such as MDS. Somatic mutations are by far the more important type of mutations for MDS, and we'll spend the bulk of our time talking about them. So again, with all of the sequencing power, we really have a better picture of what mutations are important in MDS. And this is just a small list of the mutations that are important, but the main ones that we look at clinically. So the mutational landscape, as you can see, is composed of 5 or 6 main types of mutations. There are these proliferative mutations, and these are mutations that make MDS cells grow and divide a little bit faster. And some of these mutations are associated with more aggressive forms of MDS or are associated with MDS turning into a leukemia. As you can imagine, if a mutation gives the MDS cells a proliferative advantage, it can divide quicker, it can become a more aggressive disease. Furthermore, there's these epigenetic mutations, and these are mutations that are, of course, the epigenetic mutations are probably the most common mutations found in MDS, and these mutations basically cause the MDS cells not to be able to regulate turning on and turning off their DNA. Additionally, there are mutations that are involved in differentiation, and these are mutations that allow the cells to basically become healthy red blood cells, platelets, or neutrophils. And so if that mutation is present, that process can occur, and because of that, sometimes the blood counts can be low. Furthermore, there are mutations in RNA splicing, and these are mutations that don't allow normal DNA to make normal proteins. And there's a lot of interest, as we'll discuss later, in developing therapies to address some of these genetic defects. Furthermore, we're now beginning to realize that all of these mutations are not the same. So even though we need mutations to cause a cancer, some of these mutations don't necessarily increase the risk that this cancer will progress, but some of them do. And the ones in blue are the ones that have been associated with a slightly worse prognosis for the MDS. So again, knowing that information can help refine and better kind of let us know just what is the risk that the MDS will change over time. Again, I don't want you to actually look at any of the specifics here, but again, we're now realizing that the same mutations we saw previously are associated with subtypes of MDS. So MDS with ring sideroblasts has a set of mutations. MDS with excess blasts, for example, has another set of mutations. And this has really helped us now to begin to see MDS as a molecular disease. So what may we do sometimes in clinic? And you may have heard of these panel tests, and these are some of the tests done by companies like Genoptix, GenePath, Foundation One. These are panels of genes that are important in MDS, the same genes we looked at previously in the slide, that we can now test in parallel. So before we would test one gene at a time. If it was abnormal, we'd stop, and then if it was not, we'd test maybe another gene. But now we can just test many, many genes at one time. And this is a panel test that many of us will order for some of our patients, especially if we think it's going to be clinically useful. These panels typically now are taking between 2 to 3 weeks to come back. And this used to be in the order of months, so this is getting much quicker now. So what can some of these genetic panels and what can an understanding of the mutations in MDS help us with? Well, right now this can help support or refine a diagnosis. It can also help with risk stratification, basically knowing which MDS is going to be likely to progress when which is not. We can also identify potential therapeutic targets. For example, these IDH2 mutations, which are involved in differentiation and metabolism, now have drugs associated with those, which are truly personalized therapies that really attack just the cells, just the MDS cells that have those specific mutations. And then, more importantly, we think that in the future we can use these panels to monitor disease over time. How do the mutations change over time or in response to therapy? And can we use that in addition to the blood counts and symptoms to see who's really responding, who's not, and should we be able to pick up changes that may herald progression earlier. So for the first category, supporting or refining the diagnosis, I think frequently, sometimes we see patients whose diagnosis is very suggestive of MDS, but there may be extraneous circumstances that make that diagnosis harder to make. For example, in autoimmune disease, there can be evidence of dysplasia in the bone marrow, as well as cytopenias. And in situations like that, mutational status may be helpful to establish a diagnosis of MDS. And we think right now it's not necessary to know the mutations to diagnose the MDS state, but can be helpful to, again, support a diagnosis when the diagnosis is sometimes in doubt. As you can see, MDS is frequently associated with mutations. However, states that are not MDS frequently don't have mutations in them. So again, mutational analysis in cases where the diagnosis is uncertain can be helpful. Furthermore, risk stratification right now is the primary use for mutational analysis in MDS. There are two types of mutations: mutations that are prognostic and mutations that are predictive. Prognostic mutations basically help us differentiate the prognosis of MDS on top of what's suggested by some of the standard prognostic features that Dr. Greenberg has discussed. For example, if you have an SF3B1 mutation, we know that in a low-risk MDS patient, this confers a further increase in prognosis. So these patients do even better. While if it's not mutated, well, there's no change in the prognosis. However, we're also really interested in finding and characterizing predictive mutations. A classical example here is deletion 5q. So if a deletion 5q is present, we know that more likely than not, Revlimid will work. However, if this mutation is not present, Revlimid can still work, but it's less likely to work. So again, this is an example of a predictive mutation. So again, this is just basically kind of driving home the point that, for example, the SF3B1 mutation is associated with a much better prognosis, while certain mutations like ASLX1 are associated with slightly worse prognosis. And the more mutations we have, this is going from no mutations to 3 or more mutations, the more mutations we have, the prognosis drops slightly as well, because as you can imagine, the more mutationally complex the cancer is, the more likely it's going to be resistant to therapy and more likely it is to evolve. And this is shown here in the data. The last thing I wanted to discuss is disease monitoring. So right now we're really monitoring disease by the degree of cytopenias and by the changes in the bone marrow over time. However, there's emerging research that the molecular signature can also be used to look at disease and see how it changes. And this is an example of one patient where this was done, and you can see that over time and in response to various therapies, the proportion of mutations changes and new mutations evolve, and some of these new mutations appear to be associated with then disease progression. So again, even though this is something we're not routinely doing, we think in the future with more data this is something we can start doing. And this is in a way you can think of as almost a liquid biopsy, a biopsy of the blood that can be used to track the disease over time. So how can we use some of this for treatment selection purposes? I think Dr. Greenberg did a great job overviewing some of the novel therapies in MDS, but again, I just want to highlight that for MDS states with spliceosome mutations, there's a new therapy that we're looking at here at Stanford in clinical trials that, again, addresses that specific mutation. And the thinking here, again, this is a personalized therapy that's only attacking the mutated cells and hopefully having less toxicity in the normal healthy cells. SF3B1 mutated cancers, again, this is frequently associated with ring sideroblasts, appear to benefit from luspatercept. And these trials are now finishing up, and we're waiting for some of these readouts soon. Deletion 5q is associated with sensitivity to lenalidomide, as we discussed previously. And there's actually many more examples of other mutations that may have potential therapeutic implications. And this is being more and more looked at now in clinical trials. Also, I wanted to spend a few minutes talking about hereditary MDS. So again, just kind of refresh, somatic mutations, not inherited, germline mutations are inherited. In genomics, we say that all cancer is genetic, but only 10% is inherited. In MDS, this number is actually much lower. So this 10% is across the board for all cancer types. In MDS, we think the number of inherited MDS states is actually much lower than 10%, maybe even lower than 5%. And the kind of states that may predispose somebody to MDS are some of these familial MDS-AML syndromes, some inherited bone marrow failure syndromes, and then some familial cancer predisposition syndromes, which are usually associated with other cancers as well. Again, these are diagnoses that are very rare, but we're beginning to look for some of these if the right symptoms are present in our patients and actually starting to test for these as well. So people ask me all the time, doctor, should I be tested for an inherited MDS state? And these are kind of the criteria these are the benefits of the testing, because right now, maybe 20 years ago, knowing if something was an inherited MDS state, not much could be done. But now we think the benefits of testing may allow us to modify cancer surveillance for some of these cancer states. We can suggest risk-reducive measures for other risks associated with some of these inherited states, clarify some familial risks, offer guidance in settings like a bone marrow transplant, where knowing if there's a very rare inherited bone marrow state may change the therapy, as well as identify other family members that may be at risk. So what are some of these red flags that, if are present, sometimes may suggest discussing with your physician about possible testing? Again, these are not deterministic, but if, again, any of these are familiar to you, it may be worth discussing with your physician if testing for a hereditary MDS state makes sense. And then I just want to close off on some of the future directions in our field. So more and more, in addition to doing pathological and some clinical tests, we're beginning to integrate molecular testing in our clinical workflow. And this is now allowing us not only to refine prognosis, but more and more to select the right therapy for the right patient. And more importantly, right now at least, it's allowing us to look for right clinical trials that are enrolling based on specific mutations. And hopefully, from all of the clinical and trial knowledge, this will then flow into developing new therapies that can be used clinically. And with that, I kind of want to finish, and I'll be able to take questions at this time. Thank you.
Test.
Oh. Yeah, if you can just speak up.
Would you say that it's...
Can you hear me?
Yeah.
So you were talking about mutations, and I have MDS, and I have two cytopenias. I have blast count around 10%. Give and take. My specialist has suggested a BMT, and yet I believe she did the full panoply of gene mutation, the panel, and she said that she saw no mutations. So what I'm wondering is if you could provide a brief explanation, if there are no mutations, why are my blasts behaving badly?
Right. I think it's a great question. So currently, we're only testing for between 50 to sometimes 100 genes, and we know that there's 20,000 genes in the human genome. So right now, we're only testing for kind of the hotspot regions of the most likely mutated genes. But we know that there are many, many MDS states that have mutations outside of the genes we're testing. And we're kind of beginning to expand the range of genes tested, but again, that requires more and more research to identify the very rare variants. And if we look across all cancer states, the mutation rate in MDS is one of the lowest for all cancers. On average, it's around 1 mutation per megabase. For example, something like melanoma, the mutation rate is 10 to 100 times higher. So MDS typically has fewer mutations than other cancers. In many patients, we identify only 1 or even sometimes 0 mutations. So that's completely normal.
So let me just finish up and make sure I got it, if I paraphrase. So they didn't see any mutations, but that was simply because they only looked at a small slice of the 20,000 or whatever it is. And so, in effect, the luck of the draw was bad luck for me. They didn't find the one that was mutated, and maybe even if they did, I don't know what it would tell them.
I mean, I think it's, in a way, fairly, I would say it's risk neutral. So again, I think the mutations that may be implicated in your MDS have not been well described, and we don't know their therapeutic or prognostic implications. So I would just leave it at that, yeah.
Okay, thank you.
Is there a standard of care now for the mutations that are tested for, or is that hospital dependent, provider dependent?
That's a great question, yeah. So we think that some of the very, very common, the ones with the really big circles, really are a fairly standard of care. So all major molecular panels will include those. Some of the more rare ones with the smaller circles, especially if they're not associated with any kind of specific therapeutics or strong prognostic implications, some panels don't include those right now. But clearly the trend has been to do larger and larger panels. But we have to always balance that, because more knowledge, if it's not well researched, is not better knowledge necessarily. Because if, again, we find mutation that's not been super well described, frequently as clinicians we don't know what to do with it. So we're constantly always balancing this expansion of panels with kind of our expanding clinical and research knowledge of what these mutations mean.
Okay. My question is, once a patient has a somatic mutation, I presume that they'll always have that? Or do you ever see, when you follow disease progression, that a mutation is not detected?
Yes. So we're now beginning to see that therapy monitoring can occur with some of these panels. Again, this is not ready for clinical use, but in some of the research papers, it seems that some of these mutations can go down in response to therapy and disappear, or new ones can evolve. So again, there's definitely flux in these somatic mutations, because again, these are cancer-specific mutations, so if there's less cancer, there should be less mutations. Yeah.
Could I ask, does the test that you use amplify the genes that you're looking for, or are you just looking for the base, like, number of copies that a patient might have? Well, so could it just be a detection problem when you're not seeing?
Right, for sure. So we only can look for mutations above a certain point in the blood or the bone marrow. We think that mutations that we may miss at very low levels may not be as important. It seems that mutations that are at high levels are the ones that really matter most. And we all have mutations that are present at very, very low levels that probably are not clinically significant. So we think the current testing is set up to detect, again, the mutations that are most likely to be clinically beneficial yet to know about.
Okay. Doctor, may I ask, for my mom's fish panel analysis, it says here 7q31 deletion. It's positive 20.18%. How's the prognosis, and what's the usual treatment for her?
Right. So I think, again, cytogenetics and mutations are slightly different. So cytogenetics are where we traditionally used to assign prognosis, and that's part of the IPSS and the IPSS-R criteria. So remember, the chromosomes, and that's what the cytogenetics look at, are those big building blocks composed of many genes. Mutations are actually smaller kind of mutations in the DNA within the chromosome. So what you're describing is a common cytogenetic abnormality in MDS that is used as part of the IPSS-R criteria.
It's not like, for example, you are positive for 5q31 deletion. The Revlimid is, the treatment of choice.
That's the cytogenetics.
But for her case, do we have treatment of choice?
So for that mutation, it's prognostic, but it's not predictive. Yeah. So there's not necessarily a therapy we'd use just for that mutation. But again, we would use that knowledge as part of our larger prognostic guidelines to then assign a prognosis and treat her on that. But I would say just knowing that by itself, I wouldn't be able to make a treatment recommendation. We have to look at the whole picture, yeah.
Thank you, Doctor.
Mm-hmm.
Hi, I have a question. I'm over here.
Okay.
Hi. I listened to a TED Talk. These are always dangerous things for physicians, I imagine. And it was a person who was talking about open sourcing molecules in hopes that these open source molecules could eventually make gene therapy. And it was a researcher at Dana-Farber Cancer Institute, and I'm sorry, I don't remember his name. But one of the questions I have, this particular TED Talk was on, originally aired in 2015 and repeated this summer. And one of the questions I have is, when is there going to be a new therapy? Is it, if you're in a mild state of MDS, would it be worth, putting off wondering about this gene therapy because his new molecules were talking about rebuilding cells so that they looked normal. So they took blasts and made them look like what they should look like. I'm just curious about that, and I don't know if this is the appropriate time to ask that question, but I thought you might have more information. Thank you.
Yeah, of course. So I think the first question about low versus higher risk MDS. So right now for lower risk MDS, we really focus mostly on controlling the symptoms. Because again, lower risk MDS, you can live with lower risk MDS for a long, long time. You can possibly die with lower risk MDS for something else and not from the MDS. So doing experimental therapies for lower risk MDS is typically something we don't do right now. We focus mostly on modification of symptoms, treating the anemia, raising the platelets, etc. For higher risk MDS, I think that's definitely a different story. And gene therapy is definitely something that's being looked at, but it's very, very, very early days. Because being able to effectively replace all of the mutations and all of the cells is really hard to do right now. And if, again, things like gene therapy are not able to fix all the cells, then the cells that are left over have a chance to come back. So definitely something that's being looked at across the country, but I think it's very, very far away from actually being an effective treatment for many patients. Yeah. All right. Thank you.
I have one more. To follow up on that earlier discussion about mutations and then not finding any, but only looking at a small portion, my limited understanding leads me to believe that if my blasts aren't maturing correctly and are growing and the other part, the good parts, are reducing, then something is triggering that behavior. And I'm assuming that it's genetic. And this is where you come in. So if it's genetic and I get a BMT and I get new stem cells, what's to stop whatever genetics it was causing the original blast to misbehave from not re-triggering the new new stem cells?
Well, I think that's a great question that actually lead into Dr. Muffley's talk about the role of transplant and MDS. So hopefully her talk will answer most of it. But I think, again, a transplant gets rid of all of the bad cells, hopefully, and that's why they don't come back, yeah. All right, thank you again.
Thank you. I just wanted to take this opportunity. There's a new research study. It's called the Journey Pro study. They are looking for participants, those MDS patients that have chronic anemia. Vanessa is sitting outside at the reception table. During lunchtime, you might want to stop by and talk to her if this is something that you're interested in participating in.
So I wanted to introduce Dr. Lori Muffley, who is one of the faculty in bone marrow transplant centers here, and she's done some great work over the last few years evaluating transplant in MDS and a number of other diseases. So Lori, please.
Thank you. Okay, we're gonna try holding the microphone because I know it's been a little bit soft in the back. So let me know, please, if there is a volume issue. Thanks. So I was tasked with talking about bone marrow transplant for MDS patients. And so in this audience, I do recognize a couple of our transplant patients, but I presume that most of the people here have not had a bone marrow transplant and maybe have not even met with a physician or don't plan to meet with a physician to discuss transplant. So I thought for today, it might be useful to just have a very brief overview of the basics of transplant. What is a bone marrow transplant, really? It sounds scary, but I'd like to just walk you through it. Bone marrow transplant for MDS, some of the evidence and particularly how we decide on bone marrow transplant for MDS, which is I know a conundrum for patients, but also for us physicians who are trying to make these decisions. We don't take it lightly. And then just reviewing a few of the innovative approaches to transplant for MDS that we're exploring here at Stanford that we're really excited about. So I always start with patients in the clinic by talking about what is bone marrow, because sometimes we presume that our patients understand this, and if you've had MDS for a long time, you probably now have heard of these terminologies. But so bone marrow is the soft tissue inside of all of our bones where the blood cells are made. And so we think of it like the blood cell factory where all of the white blood cells, red blood cells, and platelets are made. As most of you know, white blood cells are what comprise your immune system. Red blood cells help to carry energy and oxygen to our organs, and platelets help to control bleeding. And so the precursors for all of these cells start out in the bone marrow. What is an allogeneic bone marrow transplant? So this is very important because there's a couple of categories of bone marrow transplant. There's something called an autologous bone marrow transplant. This is where we use patients' own stem cells. We do not do this type of transplant for MDS. We do something called an allogeneic bone marrow transplant. So a bone marrow transplant is also called a stem cell transplant, and this can be confusing, but they are interchangeable, but because what we're talking about is replacing the bone marrow stem cells. So if you're reading about this topic, you may see bone marrow transplant used, you may see stem cell transplant used, but remember, it's the same thing. Allogenic means from a donor. So autologous means from self, allogeneic is from a donor. And remember, this is the type of transplant we're talking about for MDS and the majority of acute leukemias. How do we identify a donor? So when we're looking for a donor for this type of transplant, we want to find someone who is immunologically compatible. I have patients ask me all the time about their red cell type, and if their red blood cell type is the same as their sister's, would they be a match? We're not looking at red blood cell type. We're looking at part of the genetic code of the patient's immune system, and we're trying to find someone out there who is either identical in terms of that code or matched well enough that they would be compatible to receive this person's bone marrow stem cells. And why is it called a transplant? So it's called a transplant because we replace the recipient or patient's bone marrow with the donor's bone marrow. And in doing so, we ultimately replace the red blood cells, the platelets, and the white blood cells. This is a medical transplant. This is another thing I always tell patients. There's no surgery involved for the patient. So patients are not undergoing an operation as they would with a kidney transplant. This is entirely a medical replacement of the bone marrow. How do we perform allogeneic bone marrow transplant? Okay, so again, no surgery. These are the broad steps of transplantation. So step one is called conditioning or the prep. And what we're doing here is we're preparing the body of the patient to accept new bone marrow stem cells. If we were to take any one of you patients with MDS and find a donor and infuse donor stem cells into you, like a blood transfusion, that's how we infuse, your body would reject those stem cells, even if they were a perfect match. And that is because you have an immune system. It may be weakened, but it's there. And so we have to do something to deplete your immune system before we give you someone else's stem cells. We can do that with chemotherapy, we can do it with radiation therapy, we can do it with some newer novel therapies that we'll talk briefly about. The second step is the infusion of the donor stem cells. And so I should say the first step takes about a week to 14 days. Sometimes it's done in the hospital, this chemo, radiation, whatever we're using as a prep. It can be done in the hospital, it can be done as an outpatient. The second step is the actual infusion of the donor stem cells. And this is done over about an hour. It's very, very similar to a blood transfusion, which I believe, after hearing some of the questions, a lot of you have received in the past. The third step is waiting for these stem cells to engraft. And engraft really means to take. So these stem cells are primed. The donor stem cells are primed to find the patient's bone marrow, to take up shop in the bone marrow and to start growing. It's pretty incredible. We can infuse them and they just know exactly where to go and how to grow. And so that takes about 14 to 21 days or so. And this is the time period where some patients are in the hospital, some patients are outpatient, We are providing a lot of supportive care. A lot of times the patient's blood counts will be quite low from the chemotherapy or radiation therapy prep that we give. So we are transfusing and doing things to maintain the patient, but after about 14 to 21 days, we see that that white blood cell count starts to come up. And if we were to look at the DNA of the white blood cells, which we do, we would see that for most patients, it would be predominantly or entirely made up of donor DNA. And so that's very cool because the white cells switch over right away. The fourth step of the transplant process is preventing side effects and reevaluating the bone marrow to ensure that we've eradicated the MDS clones, the MDS that was previously in the bone marrow. And we do this over many, many months. So the follow-up of transplantation takes place over many months. Sometimes transplant patients are seen for years monitoring side effects and sort of taking care of the residual issues from transplantation. How do we collect donor stem cells? This is asked almost always in my clinic. And so we have two ways of collecting bone marrow stem cells from a donor. The first is called a bone marrow harvest. And in this case, we take donors to the operating room. We put them under anesthesia, and just like a bone marrow biopsy, if anyone in the room has had a bone marrow biopsy, it's sort of like a bone marrow biopsy on steroids. So we take out about 1 liter to 1.5 liters of bone marrow from the posterior hip bone of the donor. And that's why these donors are under anesthesia. And as some of you may know, the majority of our donors these days are unrelated volunteer donors. So people around the world volunteer to undergo this procedure out of the goodness of their heart. The other way we collect stem cells from a donor is by using a stem cell boosting drug called G-Csf or Neupogen or Zarzia, if you've heard any of those terms. So we use high doses of this growth factor injection, and this growth factor sends a signal to the donor's bone marrow stem cells to release the stem cells from the bone marrow and allow them to enter the bloodstream. We can then collect donor bone marrow stem cells right from an IV in the arm. And okay, so why do we perform an allogeneic bone marrow transplant for MDS and other forms of blood cancers? And so one of the reasons is that we want to replace the recipient or patient's bone marrow with the donor's bone marrow. In doing so, we replace the red cells, the platelets, and the white cells. And so I think this was on my first slide. And so our focus really is on the white cells. And why? Because the white cells become a new immune system. And this is the key to bone marrow transplant. So immunotherapy for cancer is very hot in the news right now, and I would say that bone marrow transplant is really the ultimate immunotherapy because we are entirely replacing the patient's immune system with the donor's immune system. It can be quite powerful in controlling blood cancer, but can also lead to some of the problems we see from transplantation. So as I just said, the new donor immune system can be very powerful at controlling blood cancer cells, and that ultimately can lead to a cure of MDS. Okay, so how many of these transplants do we do in this country? And so in bone marrow transplant, we are mandated to report everything to our national transplant agencies, which is very, very useful. We keep large databases on an institutional level and then on a national and international level. This allows us to go back and look at our data and to publish our data. And so we know that the number of transplantation, both autologous, which is where we use a patient's own stem cells, which we do for diseases such as myeloma and lymphoma, are increasing, and that allogeneic stem cell transplant back in 1980 when it first started to now has been increasing pretty dramatically in this country. Selected diseases for which transplantation is increasing, and so you see the red arrow is next to MDS, and so transplantation for AML and MDS are on the rise. They together make up the largest proportion of allogeneic stem cell transplant indications. The other thing that's changing, and perhaps the biggest cause for this increase in transplant numbers, is the ages of patients in which we're transplanting. And so this comes from our national transplant database. MDS is not included in this, but you can see that the number of allogeneic stem cell transplants for patients under 60 has remained relatively static over the past decade, maybe slight increases. But where we see pretty dramatic growth is in transplant for patients over the age of 60 and even over the age of 70. So 10, 15 years ago, transplanting a 60-year-old MDS patient would be considered very high risk. These days, that's our average age, and that's kind of our bread and butter transplant. And so along with colleagues from around the country, we put together and recently published a study looking more specifically at this group of patients over the age of 70, because we are increasingly seeing patients in their 70s in our clinics, and we certainly got the sense that this is a population for which transplant is on the rise. And so what we showed is that there has been an exponential increase in the number of transplants performed in this country for patients 70 and older. These are allogenic bone marrow transplants. And AML and MDS are the reason why. So we are increasingly transplanting patients into their 70s and even 75 and older for these diseases. Why is allogeneic bone marrow transplant for MDS on the rise? So historically, patients 65 and older with Medicare did not have insurance coverage for transplant for MDS. And this is important because in this country, Medicare sets the tone. So if Medicare does not approve a transplant indication or a drug or something like that, the private insurance companies tend to follow suit. And so in 2010, along with a group of researchers and clinicians who specialize in bone marrow transplant for MDS, the Centers for Medicare and Medicaid Services established a coverage for BMT for MDS through coverage with evidence development. And what that means is that they would allow patients with MDS to undergo transplant if they enrolled on a national clinical trial that was developed to look at the outcomes of transplant for Medicare patients. And so for a long time, for up until just about a year ago, all of our MDS patients over the age of 65 were getting transplant on this particular study. And so our international agency developed this study comparing, the goals of the study were to compare the outcomes of patients 65 and older getting transplant on this Medicare-approved study to historical outcomes of allogeneic bone marrow transplant patients age 55 to 64. So what they wanted to do was prove that patients 65 and older did just as well with transplant as patients 55 to 64. And this started in December of 2010. And so the data from this study was presented recently at one of our national meetings. The study compared the outcomes of 688 patients aged 65 and older with 592 patients aged 55 and 64 with MDS. Who underwent allogeneic bone marrow transplant from 2010 to 2014. What they found, and this is not surprising to those of us that do transplant, but what they found was that the survival at 100 days and 2 years following bone marrow transplant for MDS patients 65 and older is comparable to patients 55 to 64. And that age alone should not be a determinant when considering transplantation for patients with MDS. Okay, so how do we determine which MDS patients to transplant? So Dr. Greenberg and Dr. Chelation went through a lot of different algorithms and sort of ways that MDS is classified prognostically, predictively, and these are really, really important when we're thinking about transplant because transplant is a large burden to a patient and their family. It is expensive. And it's potentially has very serious toxicities. And so if we took every person to transplant with MDS, we would be exposing people unnecessarily to toxicities. So we really need to think about who really needs a transplant. And so these are some tables this is a table that is used, comes from a consensus statement for patients with very and low risk and intermediate risk MDS by IPSS-R. And so you'll see here that the first branch point is poor performance or non-fit versus good performance and fit. And Those are very subjective, but I think there's a gestalt we have as clinicians and as patients of who's fit and who's not fit. So for fit patients, if you look down the right column, poor risk features, and those are typically defined, as Dr. Chelation was talking about, by some of these molecular categories or the need for many, many transfusions. If patients have an available donor, then transplant strategy should at least be considered. That doesn't mean that the patient needs a transplant. It doesn't mean the patient will definitely get a transplant, but it means it's probably worth a discussion. No poor risk features, non-transplant strategies are recommended. If patients fail or their MDS progresses, then it's probably time to have a discussion with a transplant doctor about transplant. This is a different algorithm. This is for patients with poor risk or very poor risk by IPSSR. And so this is patients with more aggressive MDS. And so again, we look at fit versus non-fit. In our world, I would say non-fit is if patients are in a wheelchair and unable to get out of bed. They are not going to be a transplant candidate, but I think the majority of patients we see, even up, as I mentioned, up into their 70s, who are, performing their activities of daily living, out and about, are considered fit. So patients with a donor you can see here, patients with a donor with either less than 10% meroblast or greater than 10% meroblast should both at least have a discussion with a transplant physician. The question always becomes, do you need therapy before your transplant or not? And for patients with very high blast counts, it does often help to have therapy prior to your transplant. What are the outcomes after transplantation for MDS? And so this is patient's number one question, and it is very, very difficult to give specifics here. And so this is a generality for all comers. So for all comers, 30 to 40% of intermediate high-risk MDS patients will be cured following allogeneic bone marrow transplant. But some patients will have serious morbidity and mortality from the transplant process, and some patients will have recurrence or progression of MDS after transplantation. And so we know 30 to 40% is not good enough. So we're actively working on strategies to improve that number. How can we improve allogeneic transplantation for MDS? And so there's various points at which we think we can do better, and we're trying to do better. So one is with the first step, with the PrEP or conditioning regimen for transplant. And so altering the PrEP to target MDS cells is one avenue of research. With the donor stem cells, engineering or optimizing donor stem cells to better recognize MDS cells to kill them. And then with side effects, there's a lot of work done in this realm with transplantation. So reducing the toxicity is critical. Additional MDS targeting post-transplant with maintenance therapies or cellular therapies. So I'm just going to run through a couple of the things that we're working on here at Stanford. And so one is this paper comes from our group. And so we have an approach to allogeneic transplantation for older adults with MDS. And older adult means in our transplant field really as we're approaching age 70 or so. And so we don't use a chemotherapy-based PrEP at all. In fact, we don't use high-dose radiation. We use a combination of something called total lymphoid irradiation with an antibody to recipient T cells in order to decrease the immune system of the patient to allow those stem cells, the donor stem cells, to come in and take. This is a very non-toxic approach. It's given as an outpatient. It takes about 14 days. Very, very, very well tolerated. The rates of transplant complications with this approach are very low. And so this is something that we've pioneered, that we offer to some of our patients with MDS nearing 65, 70 plus years of age. Targeting of MDS stem cells. So this figure comes from one of my colleagues in the laboratory. And so we know that there are certain proteins that are expressed on stem cells and that are expressed on MDS initiating stem cells, so the group of stem cells that then form into MDS cells. And so we have antibodies now that can target these stem cells. And so this is in mice, and you can see that the mice that receive the antibody called SR1, the percent of MDS cells remaining after the antibody treatment goes way down. The problem with using antibodies against stem cells is that not only do you potentially kill off MDS stem cells, but you potentially kill off normal healthy stem cells. So you have to do something to replace the patient's stem cell, and that's what a transplant does. And so we think that incorporating these sort of antibodies might be very powerful in MDS transplantation. And so along with one of my colleagues, I am going to be leading a early phase clinical trial of one of these antibodies, plus this TLI-ATG low intensity conditioning that was on the previous slide for patients with MDS undergoing allogeneic bone marrow transplant. And so we're very, very excited about this trial, and it should be opening within the next 6 months or so. This is a study that is being run through our bone marrow transplant cooperative group across the country that's been open at Stanford for about a year, and we've enrolled about 35 patients. And so this is for younger patients with MDS, because we have a proportion of patients, particularly in the transplant world, that are under the age of 65 and even in their 20s, 30s, and 40s. And so this is looking at ways to reduce the toxicity of transplant and make transplant more tolerable, especially when we give more intensive transplant to younger patients. And so this is a 3-arm trial looking at ways to reduce something called graft versus host disease, and looks very, very exciting in our field. And then graft versus host disease, which I didn't want to get too far into today since this is an MDS crowd and probably not too deep into the transplant world. But this is one of the main toxicities that we deal with after transplant. And there is a lot of research being performed to look at ways to reduce the risk of graft versus host disease and improve the treatment of graft versus host disease. And so you may or may not have heard of a recent FDA drug approval for a drug called ibrutinib. This is a drug that's that is approved for chronic lymphocytic leukemia, so other types of cancer, but now it's also approved for something called chronic graft versus host disease. This is a drug that works on the immune cells of the body, the B cells and the T cells, to decrease inflammation. And so I put this up because David Miklos is one of my colleagues, and he led this study that led to that recent FDA approval of this drug. So very exciting, and we're using this in the clinic now, which is also exciting. So in conclusion, allogeneic bone marrow transplant is an immunotherapy that offers a potential for cure for intermediate high-risk MDS patients. The use of allogeneic bone marrow transplant for MDS and for older adults in particular is rising. New and innovative approaches to BMT are needed to further improve our outcomes. Thank you very much. I'm happy to take questions.
What are the criteria used to decide for harvesting stem cells from a donor, surgical versus non-surgical?
Well, it's interesting. It used to be that before I was doing this, the only way to do it was harvesting in the operating room before we had the technology to mobilize peripheral blood stem cells. And so it was 100% harvest, and then once we figured out that we could give growth factor and collect stem cells from the blood, it switched to almost 100% peripheral blood collection. And now it's swinging back, and that's because there was a very large randomized study that compared the two in the unrelated donor setting and found that the rates of chronic graft versus host disease are lower when we actually harvest from the bone marrow as opposed to when we collect from the peripheral blood. So these days, I think it's very center dependent. It's also donor dependent. So for siblings, we rarely will collect from in the operating room for siblings. And it's protocol dependent because some of our clinical trials mandate that that donor stem cells are collected a certain way. So there's a whole mishmash of things going on. In my practice, typically if I have a sibling, we collect through the peripheral blood. And if it's an unrelated donor, and the patient is getting an intensive transplant, we collect through the marrow.
I would like to ask. I'm a bit. I think I'm going to be doing a transplant here coming up, but I'm doing Vidasa, 3 cycles of that first. And I'm just wondering how much of in a bubble do I need to be post-transplant, and how long would they keep you in the hospital? Because my house is not that clean, and I can't imagine, just I mean I can have one room clean, but I'm wondering like what, how long do I need to be, how isolated?
Yeah, so. Here, if you're, and every center has a different way of doing this. So in our region, the 2 big transplant centers are Stanford and UCSF, and we do things differently. If you're having a transplant in the hospital and the entire course is in the hospital, it takes about a month. The hospitalization is about a month. And then the next 2 months, we do require that at Stanford that patients stay in the area. And so we set up local housing. After that period of about 90 days, our strong recommendation is that you're not in a bubble. We do this so that you can live, and ideally live the way that you want to live. That being said, there's some definite precautions, and a lot of them are very common sense precautions. For patients who are going to be home through their transplant or who are going to be discharged home who live locally, it is important to have your house cleaned beforehand. And here at Stanford, we have pretty intensive teaching and kind of a lot of nurse and social worker input on how all of those things happen. And so no one enters a transplant without those sorts of questions being answered. So if they haven't been answered and you're having your transplant here, it just means that you're probably not close enough yet to transplant, to having all those meetings.
Hi, thank you for your information. I'm coming from the UCD system, and I was just diagnosed maybe 60 days ago. So I'm really here to collect information. And of course, I put the horse before the cart, or whatever the saying is. And I have an identical twin, so I asked my oncologist about this, and she said, whoa, whoa, whoa. I am your oncologist, but actually the transplant doctors are a whole different breed and we have different training. But is that a good possibility if I have to go there to use my identical twin?
Well, so
I know, that's a lot, I know.
I'm still stuck on the whole different breed comment because we are hematologists. So we're actually, the same breed. That's a difficult question. The problem with using an identical twin for diseases such as MDS is that you don't engage a new immune system. So if you truly are identical and you have the same genetics all the way through, then you will not have that donor immune system phenomenon that we think is so important. So it depends on, it's hard for me to give you a blanket answer, but for a lot of times for diseases such as MDS or AML, if you were to need a transplant, we actually would not use the identical twin.
Okay, thank you.
But that being said, every case is different, and for one reason or another, it may actually make sense for you, depending on where your MDS is and at what level, and yeah.
Yeah, we're not there yet.
Yeah, that's good.
What are the age limits on an older person to get a transplant?
I think the oldest person that we have transplanted for an allogenic bone marrow transplant here at Stanford has been 77 or 78. We start getting a little nervous when we have referrals into the 80s, although, I did do that study of patients over 70, and there was, I believe, I can't remember, there was something like 5 to 10 patients in their 80s in that analysis. So we definitely don't use age as a discriminatory factor for this disease, because MDS is predominantly a disease of aging. And so I think that's been our biggest breakthrough, is the ability to use these therapies in all age groups.
Hi, as a low-risk patient, is it possible or advantageous to see if there's a match? Or another way to ask that is there a risk that you wouldn't have a match, so that when you become high risk and that it's time to have a transplant, there wouldn't be one
For a young patient?
Yeah.
You know, I do think, I don't know how Dr. Greenberg feels about this. I think for young people with a diagnosis of MDS, it's probably helpful to just do some of that homework, because you obviously, you know, when we look at these numbers of low risk and kind of time spans, if you're 20 years old, it's very different than if you're 75 years old and you're being told that you have a 10 to 15 years to progression of AML, for example. And so I don't think it ever hurts to meet with a transplant doctor to get some information. We always do the initial homework to finding donors. That being said, I can think of only very rare circumstances where we would take a low-risk patient to transplant, if any circumstances. So, you know, it depends how helpful it is to you.
Thank you.
Hi, it's good to see you.
You too.
I have a question about, you know, Corey had the marrow transplant from bone marrow, and now they're talking about him needing a boost.
Yeah.
Is that going to create, and I've heard it is more problematic coming from, because his donor does not want to do peripheral for the boost.
Oh.
So is that going to be problematic, and how long should we wait before we would do that if he's doing Neupogen and we're just trying to see if it is just time?
Well, we can talk about this after too, because we all kind of, we've been discussing you. We all know you well. So the specifics, you know, but I would say about the boost, that is a little unusual to not have the donor give the peripheral blood mobilized stem cells. That being said, the only difference is that the stem cell yield from the bone marrow is lower. And so it's not a better or worse. It's just that we want to make sure we have enough cells to have a engraftment. And so I mean, in some ways, it doesn't really matter as long as the yield is good. And I think that, you know, there comes a time where a boost makes sense, and that might be where you are.
Have any studies revealed any kind of complications or risk for people donating stem cells with the use of Neupogen? Has that drug had any effect?
Yeah, so
or
in my clinic, almost every week I see an unrelated volunteer donor, because Stanford is a big site for volunteer donor collection. Subset of donors are tracked forever, and every few years data is published on donors and donor health outcomes, because obviously that's incredibly important. We can't be taking these young, healthy people and putting them through this process if something was going to happen to them. There's no signal that giving Neupogen, the growth factor, to these young, healthy donors increases the risks of anything. And some of the things they look at are autoimmune conditions, cancers, and compared to, donors are compared to age-matched controls across the population. And so we always tell donors that's the data we have. We have absolutely no reason to believe that there's any harm that comes from the donation process. For donors that are getting collected with a bone marrow harvest, I always tell them the biggest risk is anesthesia. So it is an hour of general anesthesia.
Can you hear me? Yeah, I can hear me. This is a question that relates to the sort of the odds numbers that you quoted earlier, the 30 to 40%. Having read quite a bit about this, as much as I could in the time I've had, it seems to me that while there's a lot that's known, this is a very complex situation, let's call it. And so there's actually an enormous amount that still isn't known, and that what is known is not so much you understand how it works, but that you've come up with you in the medical industry has come up with a number of treatments that prove effective across a range of time and patients. So you try things and you say, oh, this seems to work. Okay, we're going to use that. And then maybe somebody comes up with a new idea or a new treatment. And you try that and say, oh, that works even better than the other one. You don't really know exactly why it's working, maybe. Some of the time you do. So it becomes kind of a data-driven, odds-driven set of treatments. So the 30 to 40% tell you what your odds are. You've quoted them, and I assume that 30 to 40% is across an age range and a severity of symptoms range. And I'm wondering if there's sort of a, being an engineer, you can probably tell. I'm assuming, if it was me, I'd be putting together a bunch of spreadsheets that showed, okay, in this age range and this severity range, and having Paretos of all of that. And I'm wondering if that kind of information is available so I can look at what my odds are and not the odds across your enormous range of people.
So, being that this is Stanford, we do treat a lot of engineers. So it's a very common type of question that we hear. Sure. And you're entirely right, because I think in our business in particular, even more than for maybe, the hematologists, it is all about odds, because there's no perfect model, and we can have everything stack up perfectly in terms of donor and disease control and age and everything else, and have an outcome that we're not predicting, and totally vice versa, where we have a patient who's not an optimal candidate, who has boatloads of blasts in their marrow and a suboptimal donor and does great. And so it does get more specific. We have just like the IPSS-R exists, we have something called the Disease Risk Index, which is broad-based, so each disease kind of has its own factors that go into it, and it's a transplant-based outcomes index. We have a comorbidity index, but I've told patients that based on their own scenario, the likelihood of success is 5%, and I've told patients that based on their scenario, the likelihood of success is 65%. And so it does become about you. And I don't know enough about you, but it is all odds-based, and it's very frustrating. And in the end, it's either 100% or 0% for the, individual patient. It's either going to work or it's not.
Yeah, it's binary in that sense, yeah. Right. I guess any of us, though, that are in a position, or at least maybe I should just speak for myself, I look at this, and granted, I have a specialist that I'm working with. And we talk about, well, what would happen if we only, if I walk away and never see anybody again? What if we take intermediate steps and not do a transplant? How does that look? Am I going to live for 6 months or 5 years or 20 years? In which case, why should I do anything? Or, should I take the risk of the bone cell transplant and the associated dangers with that? So, those are the kind of things I think we're all dealing with, and that's why I was asking you that question.
Yeah, there are more specific risk indexes, but it does often come down to a conversation, just as you said, between you and your transplant doctor, and sort of going through all of those scenarios, and that we do that all the time.
Okay.
It's challenging. It's challenging for the patient, and it's challenging for us. But if you have high enough risk MDS where the likelihood is that the MDS is going to cause you problems within the next year or two, or progress to leukemia, the discussion does become a little bit easier. The hardest discussions are for patients that have intermediate risk MDS,
Right.
where we don't know the pace of their disease and we don't know when the best time to intervene is. Because the problem with transplant is if you don't intervene at the right time, you could miss your window. And so we have patients who decide not to come to transplant, and then their disease progresses to AML, and then we can't kind of get things back together.
Right. I'm just, one last thing, I'm hogging the mic here. I thought you referred to this while you were discussing it, but one of the things my hematologist talked about was after I came back to see him, having seen the specialist, he said, did she give you the look test? And I said, look test? What's a look test? He goes, well, we look at you and he looks pretty good. So, yeah, he looks pretty good. I think he'll do well. I'm just curious, did you refer to that, or is there anything like that?
When I mentioned fit, unfit, I will say that it unfortunately, we do have all of these very well-designed comorbidity indexes and ways to kind of score fitness, but it often does come down to like a look test. But a wheelchair, that's kind of where the wheelchair is a big one. So, well, you would be surprised. Yeah.
Just a quick question. I was just wondering, are there data available that compares the low-intensity preparation to high-intensity, and which works better long-term in terms of relapse?
Yes, there are data. And so for younger adults, a study, and younger meaning these are all moving targets, and I hate that we keep talking about age, but it's just part of the way that we do things in this field. So for adults under the age of 60, 65 or so, there was just a study comparing, randomizing acute leukemia and MDS. So MDS often gets lumped in with AML in our field, but MDS and AML patients to high-intensity PrEP regimens versus low-intensity PrEP regimens. And the study was stopped early for safety because the relapse rates were so much higher in the low-intensity group. So for many of our younger patients, with the caveat of, there's the donor issue, there's the comorbidities issue, we do recommend a full intensity transplant. For our older adults, it's actually the opposite. So for older adults, if you look, in fact, in our 70 and older analysis, getting an intensive transplant was probably had the greatest association with inferior survival. So for our older adults, we think reduced intensity conditioning is equivalent to high intensity conditioning, and that's because the toxicity is lower. And so when we think about survival after transplant, we're balancing relapse and progression of disease of MDS against non-relapse issues, so toxicity-based deaths, if that makes sense. So yes, we tend to think for older adults, we tend to use reduced intensity regimens, and for younger adults, we use full intensity
So
regimens.
the threshold is basically 17 years old that you're using in this case?
I would say that in clinical practice, the threshold for most of our clinical trials is 65, and then from a practice perspective, oftentimes the threshold becomes 60 to 65. Again, taking into account fitness and certain other factors.
Thank you.
Laurie, thank you. Thank you for standing up to that. Okay. Well, we've had a big morning, and these talks, I hope, have been useful. It's lunchtime, so we'll meet back here at 1, at which time we'll begin talking about quality of life and many other questions that you still may have.
I just wanted to interject. Thank you, Dr. Greenberg.
Yes.
Mary Thomas just volunteered, and it's up to you. She's willing to start her program at 12:30, and that'll leave more room for you guys to ask questions afterwards, if you'd like. So I wanted to see what the consensus was.
12:30, okay? Let's plan on 12:30.
Okay. And there's also a back lounge, right, Dr. Greenberg, in the back that has a big table. It might not fit everyone, but for those that want to sit at a table and eat, I could show you where that room is. Okay. All right. Enjoy lunch, please.
See you back here at 12:30. Very good. a number of things for patients. Beyond our standard medical needs, has been a great person in educating me in how to deal with patients many times as well. In addition, she's come down here from Santa Rosa, and most of you know what's been happening with Santa Rosa. Hopefully her home was, happily her home was not that much damaged, other than a little more dust than she usually has. Anyhow, so I'll open it up for Mary to go ahead and start and talk about quality of life issues in MDS.
Thank you, Peter. This is an amazing turnout. And usually, when Peter actually invited me to do this, I was envisioning, you know, a dozen or so of us sitting around in a circle and having a conversation. And then when he said over 80 people registered, I thought, oh my gosh, this is going to be a lecture. How do you lecture about quality of life? So I do have some slides, but I want to use the slides pretty much as just a focus for conversation. Now, I know this is being taped, and what I'd like to do, if Audrey allows me, is if you have a comment or question, I'll just repeat it in the mic so that it's recorded, so that we can have more of a conversation throughout this presentation, rather than me just standing behind this podium and lecturing to you. I do want to say that the content that I'm going to present stems from some research I did quite a few years ago with the MDS Foundation, where we conducted 5 focus groups around the country, where we met with patients, and I asked them to talk with me about what quality of life meant to them, how MDS impacted their quality of life. And so what you'll see on this slide stems predominantly from that research, but it's also going to stem from my clinical experience in having the privilege to work with individuals who have MDS for the past several years. So I will go ahead and get started with that. So I'm going to start with a generic question that I just want you to stop for a moment and think about. And that is, what brings quality to your life? So just take a second and think about that. And if you can, try and think about that generically, not specific to how MDS has impacted it, but just in general, what brings quality to your life? So let's just let you think for a second. Okay, now I'll show you what some people have said, and then I'd like you to decide if you agree with these things or you refute them. And so you can see some of the things that I have listed here are things that most people have said, and then based on the news here, I had to add this one. First of all, I am an avid Giants fan, and given what Bochy's going through right now, I figured that that was an appropriate one, at least for his quality of life. But the point is that I wanted to bring from this is what's important to you may be different what's important to you, may be different than what's important to you. And as a clinician, if I don't ask you, I won't know. I will make assumptions, and those assumptions could be wrong. Similarly, you as a patient, if you don't tell me, I won't know. So there has to be that conversation. Now, having said that, I just thought I'd stop for a moment and say, are there other things that came to your mind that are not on this slide that you'd like to share?
Yes, a successful season for the Dodgers.
Oh, how painful. Touche, touche, very good. All right. Yes, sir, in the back.
Feeling good.
Feeling good, yes, feeling good. Yes, independence, okay. Anything else, yes? Windsurfing. Windsurfing, great. Oh, would I love that. Okay, other thoughts? Good health. So you can see that each of us probably has a little bit different idea in terms of how we would define quality of life and the importance of realizing, and I have to respect your opinion, even though I'm cheering for Houston right now, because what kind comes to our mind is going to be different than what comes to the person's mind next to us. So it's important that we think about it, but that we also make sure that we feel okay to share that with other people. Another thing that I think is important to consider is that clearly quality of life changes over time, how we define quality of life. You know, a small child is going to, quality of life is going to be getting the new puppy in the house, right? Versus a young adult, it's probably career, establishing a relationship with someone, middle-aged, dealing with children and those sorts of things. And then, of course, as we become more seasoned in our lifespan, our definitions are going to change as well. So it's also important to think about how is our quality of life changing over time, because it will, in terms of what we view as important and how we would define that. So now the $50,000 question. How does MDS impact your quality of life? So I want you to just take a second and think about that.
It takes up too much time.
Too much time. We're going to come to that point a lot. Okay, so and I will get some of your immediate responses in a second, but I just wanted to show you a diagram that when I did these focus groups and then kind of analyzed the conversations that we had, most of what people's comments focused around these various, what I call domains, various subparts of quality of life. So we have physical, functional, emotional, social, and spiritual. And oftentimes some of the comments that would fit into one of these categories, sometimes they overlap. One area might be important to one individual and less important to another individual. One component may be important now and less important later. One part may be important in the past, not so important now. So again, all of these things are in flux. So I'm going to start with physical well-being. And this is how typically it's described as all of the symptoms that we see related to anemia. Feeling fatigued, feeling short of breath, also symptoms related to therapy. If you are getting azacitidine, for instance, and you are getting subcutaneous injections, do you have site reactions, skin site reactions? Do they itch? Are they painful? Those sorts of things. And then an interesting one that some of the people in the focus groups shared was that it can interfere with your ability to have other conditions treated that you may have. How many of you have more than one health problem? Be honest. Okay, many of us do, right? MDS doesn't tend to live in amongst itself. We may have high blood pressure, we may have diabetes, we may have osteoarthritis, we may have congestive heart failure. You know, we often will have more than just one problem. And what can happen with MDS is that because of that condition, it may impede one's ability to be treated for other things, such as an orthopedic surgeon may not want to do a hip replacement on someone because their blood counts are too low. Those sorts of things can be an issue for getting appropriate therapy. And I will say that typically physicians tend to focus on the symptoms related to the disease, the symptoms related to therapy. And those are the areas that medical world tends to think about. In contrast, and this comes to your point in a moment, is how one's ability to function is impacted by MDS. And of course, fatigue is probably the classic symptom and problem that most patients experience. Do most of you have issues related to fatigue? Yeah, okay. And the issue is, and this is a hard one, I think, for patients sometimes to help physicians appreciate, nurses to appreciate, whomever. It's not that you're tired. It's that you hit a wall. And it's an oppressive feeling. It's not this pleasant, oh, I'll go to bed now. It's just you just feel burdened by the fatigue that you have. And so it's the inability to do the things you used to do as well. But it also can affect your thinking. You can have cognitive fatigue. Your mind isn't as sharp as it used to be. And then also a huge component that many people will describe is what I call motivational fatigue. Where you've got every intention of doing something, but you just can't get yourself up to actually go ahead and do it. So there are all these different kind of components of fatigue that are an issue here. And oftentimes, the fatigue levels that are experienced do not well correlate with hemoglobin levels. So when we use hemoglobin as a surrogate, we're missing the boat sometimes. So we have to make sure that we have a good way to help convey to the clinicians who are taking care of us how the fatigue is impacting us. And then, of course, alterations in pre-existing roles. Are you still able to do your job? This is particularly important if you've got cognitive fatigue and you're a business person, you're a lawyer, something like that, versus if you have the I'm hitting the wall kind of fatigue and you're a manual laborer, you're not going to be able to do your job very well. And then with that also, what is your role within the family? Are you the person who has been responsible for getting the kids up and dressed and out the door? And can you still do that? Are you the person who's always done the bills and the taxes, and now all of a sudden your mind is fuzzy and you don't feel that you are thinking clearly enough and you're making some mistakes? You just don't have the energy to do that. All of these sorts of things come into play. And then also in terms of our social roles, are we able to fully engage in the activities we want to do? Are we able to engage with our friends in ways that are meaningful in the ways we used to do them? One patient told me she used to, people would call her up and say that, did you want to go to dinner or did you want to go to a play or something? And she said, I have to check my calendar, because she would look on her calendar to see when she would likely get her next transfusion, which would give her a little bit of a boost enough that she felt that she would be okay to do that, versus otherwise she wouldn't be okay to do that. So, and you're nodding your head, yes, you can relate to that. So again, it's this whole impact on how fatigue and our ability to function can be severely impacted in ways that as clinicians we may not think about as carefully as we really should in terms of how it is for you living with the disease. And this speaks to your point about how the work associated with the disease. I think many times it is astonishing if I step back and think about what we as clinicians expect of you as patients and you as family members. And it just sort of becomes this sort of, well, come in next week and you can, and then on Tuesday you can go here and there, and you forget about what that impact is in terms of trying to adjust the rest of your life to accommodate what we feel is needed in terms of office visits, in terms of lab tests, in terms of transfusions, in terms of chemotherapy administration, all those kinds of things. And that's when everything else is going well. We're not even talking about when you have a health problem and you need to come in urgently and so forth. But then there's also, especially in not necessarily only teaching institutions, but all of a sudden you've got this plethora of healthcare providers that you don't know them and they don't know you, and there's always that little bit of tension until you feel that you've got a trust relationship with someone. So even if you're just talking about MDS, you've got a hematologist, you may be referred for a second opinion, now you're getting referred for a bone marrow transplant appointment, all of those sorts of things. Then all of a sudden now you need to meet with the staff in the infusion center where you're getting your chemotherapy or your transfusions, trying to get a sense of who these people are and how does that work. And if you're in a teaching institution, you may see a different doctor each time you come in, and that can be very stressful for people. So there's a lot of different healthcare providers just for your disease. But then you throw in if you have other illnesses as well that are being managed by someone else, And unfortunately, too many times, it's the patient that ends up being the conduit between those two for information back and forth. We're doing better now. I work at the VA. We're blessed with actually the first electronic healthcare record in the country. And so people can actually review people's charts. But if you are receiving your care in the community, your cardiologist often may be in a completely different part of town from your hematologist's office. And how well are they actually speaking with one another? So then all of a sudden the work falls on you to make sure that you convey information back and forth. So that can be a huge problem. Another thing that we see, and I was amazed at the depth of understanding from the presentations this morning. All of a sudden, you guys were exposed to all kinds of terms that you probably had never heard of before, right? I mean, what is myelodysplastic syndrome? So just trying to learn all of the terms, that in and of itself is an immense amount of time and energy. And it has nothing to do with intellect. When I take my car into the mechanic and Chuck tells me what's wrong with my car, and I get home and my husband says, so what did Chuck say? And I said, well, it was something to do with the carburetor. And it's not that I'm stupid, it's just that I don't really have a good understanding of how the car works. Well, most of us don't have a good understanding of how our body works, let alone how our bone marrow works, let alone all of the genetic mutations that we may have. So all of a sudden we're being thrust with all of this new language that we're trying to get a handle on in terms of how does this make sense to us. So that's a lot of work that's involved. And it takes a lot of time and trial and error in order to really master that. And then, of course, not only the medical terminology, but interpreting the lab tests. Does it make a difference if my hemoglobin is 9.2 versus 9.6? How do I interpret that? How much of a decline makes a difference? Why do I pay attention to having to do this math problem and get the actual number of neutrophils and not just the percentage of the neutrophils? All of these things are very, very complicated to try and figure out. And then, of course, symptoms. A patient told me she really had a hard time when she would become short of breath. She would have to step back and say, okay, now is my shortness of breath because I'm more anemic, in which case I better call my hematologist and get arranged for another transfusion? Or is my shortness of breath related to my congestive heart failure, in which case I better call my cardiologist? And it was the patient who was ending up having to make that determination. That's a lot of work that's involved in trying to figure all of this out. To say nothing of the side effects of therapy. When is it serious enough? You know, we always say, well, call. First of all, how do you call? And then secondly, when to call. Do you call for every little thing? Do you wait? Or maybe it'll go away. All of those sorts of things become an issue. And complications as well. Another thing that I think we tend to give short shrift to is the business of work with advocating for yourself. You know, you are your strongest advocate, right? Sometimes it's a family member, but it's usually you. And that's an immense amount of work. You're the one that has to keep going to bat for yourself to say, well, what about this therapy? What about that? What if I do this? What if I do that? And that is also an immense amount of work associated with that. And this last one was not mentioned too much when I did the focus groups, but I think as we're seeing more and more problems with healthcare insurance in this country, I would envision it being more and more of an issue. If you have Medicare but you don't have a good supplemental coverage associated with that, you may be faced with phenomenal bills. Or I have to get clearance from my insurance agency in order to get drug X or drug Y. Or my insurance agency won't cover this mutation panel. You know, it's all of those sorts of things that I think are really frustrating and cause a lot of angst for people as well. Next is emotional well-being, and I put uncertainty here because I think there's that the whole business of how do you interpret life life-threatening illness? How do you interpret illness experience into a way that makes sense to you? And it can stem from a whole slew of different things in terms of uncertainty about what this diagnosis is, what it means, how it's going to impact my life, uncertainty about my future, uncertainty about my functionality. Am I going to stay as functional as I am now? Am I going to become more and more disabled? Patients in my focus groups would say they would come into the cancer center and they would look around and see people with all different kinds of cancers, but they didn't know that they had different kinds of cancers, and they would think to themselves, is that going to be me? When is that going to happen to me? And so that was a major takeaway message for me of assuring people when I bring them into the infusion center to warn them that who they see in those chairs may not at all be anything related to who they are or who they might become. I think there's this anxiety that people typically have, and I'll be curious to hear your thoughts about how you are living with anxiety and how you have come to master anxiety, because I think that that's a huge issue for folks. Many patients talk about feeling very depressed, and they're mourning the loss of who they were. And I think, again, it speaks to how you define your quality of life to begin with. And if your quality of life stemmed around being a very high functional person with a lot of physical activities, or a lot of social engagements, or a very prestigious position that you no longer have, it's sort of like being forced to retire and you hadn't planned for it in any fashion. And all of a sudden, what do I do with my life, and who am I, and how do I make sense of all of that? So that's a large one. And then, of course, another one that causes people to feel very depressed is when people say, well, you know, there's no cure for this disease other than bone marrow transplant. Well, yes, that's true. But if you think about most medical illnesses, we don't have a cure for most of them. We don't have a cure for diabetes. We don't have a cure for congestive heart failure. We don't have a cure for emphysema. We don't have a cure for high blood pressure. We can control those illnesses well, and that's what we're hoping to do with MDS, and to control it well so that you can live functionally. But I'm always concerned when people pick up on this lack of cure without there being this context of that's true for a lot of what we're facing in our lives. But how best to live with it, and to live well with it, and to feel good in the process. Another factor that comes into play for many people is the issue of loss of control. You've been a business executive all of your life. Whatever it happens to be, you feel that you've always had the ability to control what happened, and perhaps to control people below you in a hierarchical setting. And now all of a sudden you feel like you have no control over what's going on with your body. And that can be very, very distressing for folks. Interesting, and I'm curious, as we and I open this up for conversation, if this was an issue for you. Many patients described at great length the shock they had when they were diagnosed with this disease. And what was interesting to me was that for many of those people, they had been living with this disease for 5 years, 7 years, and they still had this need to talk about the shock of receiving that diagnosis. That was very striking for me to learn about that. And then I think, again, the whole business of what does the future hold for me. In terms of social well-being, again, this whole business of time that's spent away from doing things. My son was out having hip surgery a couple weeks ago, and I went with him to his orthopedic appointment and then to his physical therapy appointment. And it just, you know, being on the receiving end as opposed to on the caregiving end, it's always interesting to get a sense of what it's like to sit in that waiting room and wait and wait and wait, you know, and then to wait for them to come out, and, you know, all this, the time, and it's it is what it is, but it's time that you could be doing other things, right? Especially if it's a time where this is a time when I feel good and I'm wasting it sitting in this waiting room when I could be out doing something else. The whole business of how do I plan for my future? We're all mortal. We will all die at some point in time. None of us know when that's going to be. How do I plan for that? Does living with MDS impact that in some way? And if so, how? When am I supposed to give my kids my inheritance? Do I do it now? When, do I do it later? It's interesting to hear some people talk about those sorts of things. And then the whole business of activity restrictions. I had one woman, it was just heart-rending. She said to me, I don't know if I can hug my grandchildren because my white blood cell count is low. Ability to travel. We warn people about all of the nasties that are in the air circulation on airplanes, and yet when you think about it, that's our primary mode of travel from point A to point B anymore if you're beyond 100 miles or so. And so how does that impact your social well-being? Talked a little bit about relinquishing roles earlier, but when you have to give something up and somebody else has to take it on for you, how does that impact their quality of life? How willing are they to do that? How skilled are they to be able to do those things? So all of those factors come into play as well. How do I continue to feel like there's something normal in my life? And can my life be very normal? Is it completely abnormal? How can I move it from less normal than I want it to be to more close to the normal I want it to be? Sexuality can be a huge issue. Part of it is fatigue, part of it is anxiety, part of it is depression. All of those sorts of things come into play. Not only in terms of sexual activity, but just in terms of your self-concept about who you are as a sexual person. And then from that also comes strained interpersonal relationships. Again, this whole business of having to redefine roles within a family or within other people, relationship with you, and how does that impact your relationship with them when all of a sudden they're the ones that are stuck doing all of the housework or the bill paying or the child care or whatever it happens to be. Are you still able to work? If you're not able to work, are you okay financially? Or now all of a sudden is this a huge burden for you? Or how has this impacted other people? A woman was no longer able to care for her daughter's children. All of a sudden the daughter now had to pay someone to take care of her children. She didn't have the financial resources to do that. So it can, there's that ripple effect that we can see. And then of course with that comes the financial strain. In terms of spiritual well-being, it was very interesting to me in not only from the focus groups, but also my work with patients over the last many decades. Clearly some people have this feeling of hopelessness. But what is amazing to me is the resilience people have, especially over time, when they are able to adjust to the new them, and to see how it has impacted them in a very positive way. And I just have listed here things that they have articulated to me over the years that I find very amazing, and it just never ceases to amaze me how people can react to things and turn, the infamous is the glass half empty versus half full, and how people can see a glass that looks pretty darn empty and make it very, very full because they've been able to change how they interpret things, how they reestablish their priorities, and finding meaning in this illness that they happen to have. So I would like to now stop. I've been talking about what I have heard other patients say. So I want to go back to that slide just to help us remember. Are there other things that you think of that the MDS has, or its treatment, has impacted your quality of life in any of these dimensions that you'd like to share? Or things that you think haven't been covered from what I've shared thus far? Yes?
I think under functional, my particular case, as my husband can attest to, I always felt myself really independent. You know, I worked for years, and then I got MDS. I was diagnosed about 7 months after we retired. And he's had to take over the times that I would normally drive myself somewhere, so to speak, where right before I get blood, I feel lousy, as all of you guys know, so he has to take me in more often than not, actually put me in a wheelchair to take me to get to the lab work done. The next morning, we turn around and get my blood done. So the functional part of it sometimes has been really hard to give up because I just need him to do that for me. But yet I feel guilt because my husband's very active.
I can't drink her.
Too big for that.
A lot of people, thank you for bringing that up. So what she said was she's always been a very independent person, very, very functional. Now all of a sudden she's having to rely on her husband, and she was diagnosed right after retirement. Thank you very much. What a lovely retirement gift. So she's now having to rely on her husband to have to drive her before she would, of course, drive herself. She has to be driven to get her lab tests done. She has to be driven to get her transfusions. Her functional status can decline enough that he has to put her in a wheelchair sometimes to get her in and out of places.
I got to give her a little bit after that. Would she do that for me if I was in her shoes?
Yes.
That's the way I think. That's why I do it for her. I know she'd do it for me.
There you go.
That's true, but that guilt is still there sometimes.
Sure, sure.
He has to give up an activity. It's important to him.
So I can do it again.
But your point about feeling guilty, I'm sure that is something that I've seen a few nods head. That is a very real feeling that people have. And it's hard to let that go. I think what you are doing by sharing, but you would do that for me if the shoes was reversed. I mean, thank you. But also, I think that can help. I think there will be times, of course, in any relationship where that stress does grate on people and you want a break and you don't get a break and it becomes an issue. But, if you have a solid relationship to begin with, it often will wear through a little bit better than if you have a shaky relationship to begin with, of course. Somebody else had a comment. They went, yes.
This is a general comment for the, and I don't know if you have any comments. The medical profession, in my humble opinion, is really low on information regarding cost. And I actually, if I have to be angry and frustrated about one thing, is I still don't know the cost of this. And my husband's, we're going to have to pay a lot of money. I'm a sole practitioner in my own business. And I think that needs to be way more upfront. And we've yet to have anybody sit down with a piece of paper that says, a cycle of azacitidine is this much money. I'm really very, very frustrated by that.
I don't blame you. Now, I work at the VA, so I'm spared that reality because most of my patients get absolutely everything for free or very. Now, wait, let me finish. There is a copay for some, but that is the direct cost of the therapy. That still doesn't take away from the cost of you having to take a day off or whatever without pay. So there's that piece. But for those, and this is where I don't want to get political here, but our insurance system is just in such a mess because what Stanford charges for azacitidine is going to be different than what Hospital X charges for, which is going to be different than what Dr. Y charges, and what insurance pays can be different from Plan A versus Plan B. And so how one can, you're shaking your head no.
I believe that the medical practitioners in the room should have some idea of the costs. And that's what I find lacking.
Yeah.
When I ask my physician how much it costs, there should be some general notion of that.
But in the old days, and Peter, you can respond to this in a second. In the old days, at the VA, what we would have when we would have prescriptions that needed to be renewed, we would have the cost of that prescription listed. And that was very, very helpful. That's gone now. And so we don't necessarily know. But it is a major challenge. And please use the microphone so people can hear your response here.
It's a great question, and it's an important one.
Talk loud. Hold it up to you.
It's an important one. One of the problems we have is how do we modify drug company costs and what's covered. Analysis has been done of these costs. They're published, okay? So that, for example, the cost of azacitidine, decitabine, XJ, lenalidomide for a year, as approved by various guidelines, has been published, and it's known what those are, and I can give you those figures. It's true, though, doctors don't really know about it, number one, and number two, they don't know what your insurance will cover. Usually insurance will cover most of it for patients that are in Medicare, but not always. But most importantly is the cost that drug companies charge. And at the moment, until there is a stakeholders meeting with everyone, and that is political, that is when you talk about government as well as insurance companies, as well as physicians, the drug companies will not modify their costs. And so that's a huge issue that's really going to take a political change for that to happen. If you want the amounts, I can give those to you at some point, not necessarily now, and we can certainly talk about that in detail. Yeah.
But it is a moving target because what a drug company will charge in year X may be very different than what it's going to charge in year Y. And how, you saw the slides from Alex on the genetic mutation stuff. We are bombarded with so much information now. It's hard to keep up. Your point is a very valid one. I don't know that it should be the physician who should be able to tell you that, but you should have ready access to that information when you go in. Absolutely. I fully agree with that point. Anything else anybody else wants to share about how MDS has impacted your quality of life? Did what you saw on these slides, did that sort of ring true for you for at least some of it? Okay. Yes?
For long-range plans, like planning trips and buying tickets,
yes.
You have, well, maybe I shouldn't do that because I'm not sure just what my counts will be or if I'll be, started on a different med or something like that. So it has impacted something even like remodeling a kitchen or anything like that. It does impact your planning of future projects.
Right. So for those of you who didn't hear, it's how it impacts your ability to plan for the future, be it something like remodeling a kitchen to taking a vacation and trying to figure out, will I be able to take a vacation at that time based on, will my treatment be changed? Will my blood count support it? Will my energy support it? All of those sorts of things. How do I try and plan for something in the future? And the future may just be a few months, let alone years. But how do I fit that in? Anything else? Anyone wants to share? Yes.
Coming from Vallejo today, I could have got killed at least 5 times on the freeway. Easily. So thinking about a year from now to go on vacation, plan it and think you're going to go because some other thing might step up. It's not going to necessarily always be MDS. So to control your life a year from now and say, well, I don't think I can do that because there's a whole bunch of other things in our world today that can take you out without trying to force that in. So in my thoughts and the way I'm living is, next May I'm going to do this, I'm going to do that. Yeah, you're going to put a little bit of money down maybe for a deposit or something. You might lose that. But to try and keep your life going and have some sort of quality and then be worried about, well, what's going to happen a year from now, that's just my thoughts.
Did that come through adequately on the tape, do you think? Oh, too bad. Because the way you said it was so beautiful, and I'll butcher it. But the point was, don't allow this disease, and please let me know if I paraphrase this accurately, don't let this disease control your life. There's something else that could take your life at any point in time, and you had cited, you could have been your life could have been taken from you 5 times driving here from Vallejo today. I can relate, commuting from Santa Rosa, believe me. I was right next to a car that was hit by a car. So, you know, there are all those sorts of things. 2 weeks ago on a Sunday, I was at a winery tasting some wine and had friends over for dinner. 4 hours later, there was this massive firestorm. Your life can change in a split second. You just don't know. And so your whole point about not allowing this to immobilize you, but to move forward is very important. Not easy to do necessarily, but that's my job as a clinical nurse specialist to help you to do that if you're my patient, to support from your friends and family, from the rest of your healthcare team. The MDS Foundation does a great job. Jack is here from the Leukemia and Lymphoma Society. They've got some wonderful information and resources for you. So it's very important that you try and make sure that to the extent you can, you may have to redefine your life a bit, but it doesn't have to control your life. I want to close with just a couple of points and then a couple questions for you. One is managing fatigue, because I know that that is by far the most frustrating symptom that many people have with this illness. And I think that when you come into the hematology clinic, way too much we just focus on what is your hemoglobin. And will you get a transfusion or not, or do we adjust your EPO level or not? And that's it. But there are a lot of other things that can impact one's fatigue in addition to anemia. And so there are some things that you can do that can make a huge difference. When I say exercise, I do not mean that you need to join a gym. I do not mean that you need to start training for a marathon. I do mean that you need to be as mobile as you can. Our bodies are meant to be mobile. The more sedentary we are, the weaker we become. Our leg muscles and our thighs just deteriorate, our lung capacity diminishes, and we feel worse. We sit more, we feel worse. It's a downward spiral. So even if it's just walking to the mailbox and back, even if it's just to the corner and back, that can be a huge difference in terms of staying mobile and helping a little bit with that fatigue. One of the things that we all face as we age is we lose our sense of thirst. Staying hydrated is very, very important to keeping your energy level up. And if you wait until you're thirsty, you're probably not going to get as much fluids in as your body really needs. So think about how much do I really drink. And I'm an avid coffee drinker. So my coffee that I have in the morning, my 4 cups, does not count in my fluids for the day. I have a cutoff at noon, and then from then on it's water, so that I make sure that I get the water that I still need in the course of a day. Come up with some strategies that work for you. For my brother-in-law, I had him put out 6 glasses on the kitchen counter. And so he would see it was 1 o'clock and he still had 3 glasses there. You know, when you drink a glass, you put 1 away, so that you, by the end of the day, you have an empty counter. Whatever cues you need in order to help yourself remember to make yourself stay hydrated, because you can't rely on thirst. A lot of people will always ask, well, what about nutrition? Should I be taking supplements? What kind of food should I eat? It's very frustrating, but sadly there have not been enough well-designed, adequately carried out studies to really help us know what is needed. What we can say is a well-balanced diet makes sense. There was 20, 30 years ago, there was this big push on what we called a neutropenic diet to make sure that there was no fresh fruits or vegetables. Everything had to be well cooked. Limit blue cheese, limit this, limit that. They have since relooked at that body of evidence and decided that there wasn't any real substance to that evidence, and it was more just an opinion at the time, and it sort of carried through. So having said that, there still is a lot of common sense that you should pay attention to. So for instance, if you are a lover of salads, think about where that lettuce is. The lettuce grows in the soil, right? Soil is full of organisms. So you'd want to make sure that that lettuce is washed exquisitely well before you use it, right? So you wouldn't just go to a salad bar at the grocery store because maybe they might have a little nodding acquaintance with some water, but likely not even that. So you'd want to make sure that you take the lettuce home, wash it well, that sort of thing. So thinking about what kinds of foods you're eating. Still a little, I'm personally a little nervous about people who want to do the raw fish and shell, seafood stuff, because again, how you know about those sorts of organisms. But, so things change over time. If you're eating a well-balanced diet, that's probably all your body needs to our level of understanding right now. But you should ask your doctor, has your B12 level been checked? If you're, especially if you are a vegetarian, how well are you doing on making sure you're getting the adequate supplements your body needs? Is your magnesium level okay? You can feel really crappy if your magnesium level is too low. Is your salt level okay? We're worried about salt restriction, but making sure that your sodium level is okay too. So making sure that those sorts of things are well balanced as well. Making sure that your thyroid function is still okay. That can certainly become an issue as we age, and that can certainly be a huge impact on fatigue as well. Yes?
How do you feel about relying on things like Boost?
Boost? If somebody has a problem with appetite and they really are having a hard time getting food down, it certainly is better than eating 3 bites of something and say, I'm done. But if you're eating a well-balanced diet anyway, you probably don't need that extra, especially the extra sugar that comes associated with the Boost. But again, it's a function of getting a sense of what is someone's normal diet, how much are they eating of that normal diet, and then do we need supplements as well? And then that would make sense.
And how do you feel about appetite stimulants?
Appetite stimulants. So there are a couple, one of which tends to make people a bit more prone to having blood clot disorders. So you would definitely want to talk with your provider about starting that and see what the pros and cons are for you versus not. Some patients find marijuana to be a useful appetite stimulant. I'm always concerned about anything that gets inhaled into lungs, so marijuana is included as well as tobacco from my perspective, but it's those sorts of things that you have to kind of weigh in. And some of the others, it's a function of you might need a much higher dose before you'd actually see an effect. So I would definitely have a conversation with your clinician about pros and cons and which one might work best in that particular situation. Any of you having problems with sleep? Yes.
I have a question.
Sure.
Is it possible to take in too much protein?
Too much protein. If your kidneys are having problems, yes. Your kidneys have to filter all that protein, and a very, very high protein diet can impact your kidney function in a not good way. So yes, there's too much of anything can be a problem, including protein. So sleep disturbance. I just told you need to drink all this fluids. Well, great. Thanks so much. Now what's going to happen to me during the night, right? If you're trying to get all those fluids in, have a cutoff. I'm done by 4 o'clock in the afternoon so that I have those extra hours to try and get that out of my system before I try and go to bed, and then don't have to get up quite so often during the night. Men certainly have more of a problem with that than women. Women had their problems earlier in life. It's retribution time for men. Simple things, though. When was the last time you had a new mattress? It's amazing. A lot of my patients say, I've had it for 35 years. Well, if you consider getting a new mattress, oh my gosh, what a difference it made. My sister had what she would deem restless leg syndrome. She got a new mattress. She has no problem with restless legs. I mean, sometimes it's these simple things that we just don't think of because we think, well, it's a medical problem, we need a pill. And then all of a sudden we're trying to balance taking 36 pills. Sometimes if we think about other things, we can come up with some sort of simple solutions to things. Is the ventilation, is the temperature right in the room? Is it too hot? Is it too cold? There's been some interesting research lately on the ill effects of all of the blue lights from all of our electronic devices that are in our bedrooms. And how can you get rid of that blue light so that your sleep patterns become a little bit more normal. So all these little things that we can kind of consider to do. And then, of course, making sure one's pain is well managed. And that can be physical pain, it can be emotional pain, it can be spiritual pain. Making sure that that gets managed to the best it can be as well. And then, of course, last but not least is to improve the anemia. So I want to end by just asking some questions of you to consider. Does your spouse or other family members share your view of quality of life? And is that helpful? And if they share a different view of quality of life, is that helpful or does that become a barrier for you? Does your doctor understand how MDS impacts your quality of life? Why or why not? Well, they never ask. Okay, do you tell them? Has to be a two-way street. You have to be the advocate, and I appreciate that that's a lot of work. Do you use your thoughts about quality of life when you're making decisions about therapy? You know, we always say, well, but you come in and the doctor says, oh, I think it's time, based on your counts or your last bone marrow results, we should go on azacitidine. I'm just pulling something up out of the air. Well, how is that? Tell me more about the treatment. What is the work associated with that treatment? How am I going to feel during that treatment? And then make those decisions about how well that impacts your quality of life in a positive or a negative way, as opposed to looking at, I'm treating numbers. Dr. Greenberg alluded to that earlier when he said in his practice, he transfuses based on symptoms, not on numbers. I wish that were true for more clinicians.
How do we get that thought out to the hospitals so they're making the decisions about a certain number?
It's a real challenge because there have been a lot of studies that have been done in acute care settings, in the hospital settings, and particularly in the ICU, that showed that people who had who were transfused with a hemoglobin level, a higher hemoglobin level, did worse than if you let it down at 7. In the acute care setting, you are staying in a hospital bed. You may be getting up to a bathroom and back. You're put in a wheelchair to go down to x-ray, that's it. You're not trying to live a life outside in the home. You're not trying to prepare meals. You're not trying to get to and from the doctor's office. You're not trying to still go out to dinner with someone. And sadly, what has been done is with those studies, we've extrapolated that from an insurance perspective usually, that we shouldn't transfuse unless the hemoglobin is less than 7, 8, 9, whatever. Right. And that's where then it becomes, it's not to say you can't do it, but it requires then a lot of extra work on the part of the clinicians to defend why in this particular patient you need to do that. And if you think about it, if we were to raise the threshold, I'll just pull a number out, say 10, and we kept it at 10, we wouldn't be necessarily giving any more transfusions, but your ability to feel better would be probably, and be able to function better, might be better than if we kept it at 8, which is a very common one in the community.
Well, we've been through all this because you transfuse at 8.4 and only brings you up to 9.5 after 2 units.
Yep. Yep. Yeah, and No, it doesn't. And that's, I think, the other thing. We think about it, well, it's, and as Dr. Greenberg alluded to earlier, we know that chronic anemia puts more of a strain on the heart. And so I think, again, as a patient advocate, to help people, clinicians, to appreciate that, but well, what is it doing to my heart by keeping my hemoglobin at 9.2? Because they might not be thinking of it from that perspective. So again, it's that sort of work that is expected of patients in order to bring that back, to help remind people sometimes of those sorts of things. Yes?
I think this is the right place to come in. I was talking about what I feel like. I go to Kaiser.
Yes.
Kaiser for like close to 40 years.
Uh-huh.
And my particular transfusion center and my hematologist and all of the team, I'll call it the team, in the last year has decided to put embedded with the team a psychologist. And she's not like another building, because we do have, psychologists in another building with Kaiser, where I go. She's right there with the team in the clinic. And I started going to her recently. And of course, she's dealing with people who just got diagnosed, people like me who've been living with it for years. And I really feel like just having met her and having her in my life now has helped me a little bit, because I liked her immediately. She just looks at you right in the eye when she talks to you, and she just picks up on things. I just think it's fascinating. And so, I mean, I don't know if everyone else, where they go and doctors they go to, but this is something new with my particular team that I work with.
So this woman has the luxury of having a clinical psychologist embedded in her care team at her Kaiser facility. We are fortunate at the VA, we have a clinical psychologist embedded in our team, as well as a social worker. But I'm curious, do others of you have ready access to a psychologist?
Social worker.
Social worker, okay, good. Nurses that are talking with you and not just giving transfusions? Yeah. Okay.
Is there any, I know we haven't said anything about the spiritual piece.
Yeah.
Is there a person embedded that's the spiritual? I would imagine it's spiritual care, a chaplain, or do you really go into that, or is that a nurse? Or?
It depends on who you're dealing with. Some nurses will feel comfortable with that. Some physicians will feel comfortable with that. Others won't. Some psychologists will, some won't. At the VA, again, we're very fortunate. We do have a chaplain staff full-time in our facility, so we always have access to that. Some people find their own religious leader from their own church is very helpful, or synagogue is very helpful. Others don't say, well, I'm not religious, but I'm spiritual. And then they don't want that conventional kind of pastoral care, but they still want to have that opportunity to talk about the spiritual thing. There are some support groups out that have sorts of things. There's a wonderful one up in Marin. I appreciate that's not convenient for a lot of people. But look around. There are venues available if you feel that those needs aren't being able to be met with your own care team. And ask your care team members. It's a perfectly appropriate question to say, so I really feel that I have some spiritual needs that I'd like to have addressed. Who might I meet with to have that happen? And see what they say. They may not be able to do it, or they may not feel comfortable doing it, or they may feel that they don't have the skill set to do it, but they should be able to direct you to someone who could.
Well, thank you. I just noticed because of we're living longer and stuff, I see a lot of the palliative care stuff going
Yes.
on.
Yes.
We have hospices now. And,
Yes.
But even before that point, I don't see it.
Right. And the whole business of bringing palliative care in at the beginning of someone's diagnosis with a potentially life-threatening illness, we're not anywhere close to that. And we don't have the manpower to do it for every single one, so it still is a challenge. Yeah. A couple more questions to consider. Think about how your MDS has impacted your life beyond the fact that you're not as young as you used to be. I think, most of us, for me, it's like I see a picture of myself and go, oh my God, what happened here? I don't view myself as being 62. I view myself as being 40 or sometimes even younger. And so a lot of us, I think, have that issue in our heads of we're really younger than we truly are. And so some of what we're experiencing is simply the impact of aging and not necessarily the disease. Other times it's the disease has certainly thrown it a bit further along. And then thinking about the financial problems you might have, and is your job currently a help versus is it a hindrance? And if it's a hindrance, are you financially secure such that you can leave that job? Sadly, many people, that's not the case, and so that still is an issue for them. And then to consider if your family and friends help versus they interfere. Does your faith help or does it interfere? And does your attitude help or does it interfere? And for any of these things that it does interfere, consider how you might take it and try and turn it in a way so that it's less of an interference for you. So last slide that I have is to decide what in your life is truly important, what truly brings quality to your life, and to decide what isn't and what doesn't. Can you still do at least some of the things that really do provide quality to your life? May not be as many as you want. That's true for many of us. But are there still some that do? And are those the ones that are most important to you? And to consider again how your treatment, how the illness, and other health issues you may have could interfere in that regard. Before I break for any additional questions, I did want to mention this at the beginning and I forgot. Jack Aiello had brought this to my attention. If any of you have gone to this in the past, you know how excellent the Leukemia and Lymphoma Society sponsor a conference every January, and they're in San Francisco. And within that conference, there is a session on MDS. And this year, Dr. Brian Jonas from UC Davis is going to be the facilitator for the MDS session. And they're also going to have a caregiver session at this event. The date is January 27th. And it's going to be at the Hyatt Regency in San Francisco on the Embarcadero Center from 9 to 2. And if you go on the Leukemia and Lymphoma Society website, soon they will have the registration for that. It's not quite up yet, but I would really encourage you to take advantage of this excellent opportunity if you can. Okay, with that, I will ask if anyone else has any other questions. Yes?
I'm sorry, when you were talking about nutrition, and
yeah.
you were talking about hydration. My mom has congestive heart failure
Mm-hmm.
as well. So how does she balance the intake of water that she needs for her anemia and her
Yeah.
like that?
That's always a challenge. Are you weighing yourself regularly? Okay, so what your weight is going to tell you how well or how much you overdid the day before. Yeah. And then the other thing that I would consider for you is making sure that you're paying attention to your sodium intake so that that's not, the chicken broth and all those kinds of things are probably not in your best interest. And I see some very nice thin ankles, so you're doing well at the moment, and hopefully that can continue. But then that would be a good question to work with your cardiologist as well as, I know I should probably get at least 4 or 5 glasses of fluid in, and how well does that work for you? Good question. Any other questions? Yes? Make yourself gain weight. So is it an appetite issue, or you start to eat and then you get full very quickly, or you look at the plate and you go, there's no way I can eat this? Uh-huh. Couple of strategies that I have used that some patients have found effective, but not all, of course. Get yourself a big dinner plate. Put very small amounts on the dinner plate. Rather than a small plate, big plate, little pieces, and say, I can get that much in. Oftentimes what happens is you see a plate of food and you go, there's no way. It's too much. So it's a quarter of a sandwich, not even half a sandwich. It's just a few bites. And then you need to do what my mother would call grazing. So every hour, 2 hours, it's just a little bit of food throughout the day, as opposed to trying to eat the standard 3 meals. It may be 6 or 7, but it's very small parts at a time. And then the other thing would be to make sure that what you are eating has a lot of calories and protein, and then if you need to, a vitamin supplement to go along with that. But then within that, something you actually enjoy eating. And again, it may only be a couple of bites, but making sure that there's something of that as well. And then beyond that, then I would encourage you, if you haven't, to meet with a dietitian to see if they have some additional strategies for you. Yes?
Are there forums for more specific types of MDS? For instance, in my case, I'm interested in CMML.
Are there different forms for different types of MDS? I think one of our biggest problems with MDS is that we use one label for 5, 7 different diseases. One size fits no one. And that is a major challenge that I think we find. And our problem, and you're particularly, I'm glad you pointed out CMML because it behaves considerably differently than other forms does. To find enough people with that particular type that you could then have a meaningful support group is a challenge. It's hard enough to just to get MDS, but that is too much of a mixture of different folks. You're probably better off if, a couple of suggestions I would have. One is to call the MDS Foundation and see if they have anything specific. Your local here, I'd call the local Leukemia and Lymphoma Society chapter. See if they can pair you with an individual who has CMML and get some support from that individual as well. Because all of the local people through the Leukemia and Lymphoma Society have gone through some really good training for providing support for folks. But you would want that one specific disease type. It's right here.
Excuse me? Does everybody know about the MDS forum online?
Well, I would hope so because you're here through it. But yes, that's the other point, and that's what I said. It's really the MDS Foundation. So when you go on the MDS Foundation's website, there is a forum, and you can certainly get some information and also support through that as well. But your point about targeting a specific subtype, that's where we really struggle, and I think we fall short.
One of the things that I would comment on is that the CMML is a hybrid type of disease. It's a spectrum between MDS and myeloproliferative neoplasms. There is now, I mentioned earlier, the NCCN, National Comprehensive Cancer Network. There are guidelines. Those guidelines are available for patients as well as for physicians. So for MDS, there's one set. CMML is covered in there somewhat, but there's now new guidelines for myeloproliferative neoplasms that includes CMML. So that group of diseases is now being covered at least by the NCCN, and so you could certainly read there. You have access to it. You just indicate what subdisease you're interested in. And CMML has similarities and dissimilarities from MDS, including some of the mutations that are present. And so that set of guidelines can let you know where the disease is and what kind of treatments are suggested.
Yes?
And for the first time, the Leukemia and Lymphoma Society meeting this year in January had a group for myeloproliferative neoplasms, which includes CMML. And so hopefully they'll continue to do that until the meeting in 2018. So that would be a good one to do.
right to vote tonight.
So for those who didn't hear, so at the Leukemia and Lymphoma Society meeting on January 27th, in addition to a breakout session devoted to MDS, there will also be a breakout session devoted to myeloproliferative disorders, and CMML can fit in there sometimes better than in the MDS. It kind of depends upon which flavor of CMML you have. But again, to speak to your original question about support, I would suggest either through the forum to see if there's someone there or through the Leukemia and Lymphoma Society. Any other questions, comments, things one would like to share? Yes?
My husband has a problem when he's after chemo treatments that he doesn't have an appetite because of the metal taste in his mouth.
Uh-huh.
Is there any way we can counteract that?
Try using plastic silverware. It's the metal forks that's the problem. Anything else? You guys have been amazing. It's been a very full day. Thank you so much for your time and attention and for your contributions to this discussion. It's a real privilege to be here, and I thank you. Take care.
Thank you. It's been a great afternoon and morning. Please keep in touch. Mary and I will be here for a little bit to answer some questions if you still have some.
Thank you.
Thank you.